he was 63 years of age, you could actually see a change in his visual palette. Things were farther away over the time of his painting. So if we look at his self-portraits, several of the 85 self-portraits in various media, paint, oil on copper, lithographs, designs, engravings. You can see that Rembrandt's palette became browner, more brunescent, less sharp, and that again may have been due to, this is hypothetical, due to nuclear sclerosis. The question of cataracts has been raised also in the great British painter Joseph Mallord William Turner, where his early works seem to have more detail and his later works are more impressionistic, as we can see here, but it's not really a one-to-one correspondence. And for example, here's a later work, 1848, which has a bit more detail and specificity than a more famous, more impressionistic earlier work from 1842. As I mentioned, Honoré Daumier did have cataracts, did undergo bilateral unsuccessful cataract surgery, unfortunately. Daumier, you may know of as that painter and lithographer of caricature. He was a painter, a draftsman, a lithographer, and a sculptor, an incredibly diverse brilliance in this great French artist. You may recognize some of these caricature type of prints that he did. Here's just the print collector. These are two Commedia dell'arte characters, Crespin and Scapin, that he painted in 1860. Charles Baudelaire said of Daumier that it was Daumier whose image we offer you and whose art, subtle among all, to teach us how to laugh at ourselves. As he got older, his palette also became more brunescent, and this is a good example, the imaginary invalid from later in his life. Again, that brunescent, that monotonic brownish kind of palette. One wonders, sure, you could say this was style, the same thing we could have said with Titian, that it was stylistic that he chose to use more browns and sepias and umbers as opposed to reds and greens. But I think that someone who underwent cataract surgery clearly must have had visual loss to require it, especially in the 1800s, way before we had extracapsular cataract extraction that was successful and phaco emulsification. Mary Cassatt, another example of a great artist, an impressionistic artist, and one who did develop cataracts in her later years, which of course affected her greatly because like Honoré Daumier, unfortunately, Mary Cassatt's cataract surgery was not successful. You know, many of her works have to do with the mother and child genre, the love and the intimacy between the mother and child. And as Cassatt aged, she was born in 1844, so once she reached her 70s, she developed bilateral cataracts. It's thought that that was due to radium therapy. She had diabetic retinopathy. She underwent cataract surgery in 1917 in her right eye. And as you can see from the quote from her writings, she says, "My sight is getting dimmer every day. I find writing tires my eyes. I look forward with horror to utter darkness and then an operation which may end in as great a failure as the last one." She underwent cataract surgery in her left eye, despite the bad outcome in her right eye, and developed posterior capsular calcification and did not have any further surgery. Claude Monet brings us and gives us the most detailed evidence for what cataracts can do in terms of visual loss and visual changes. And again, as I alluded at the beginning of my talk, he did not stop his artistic journey. He just kept going, and it clearly just changed the way he saw the world, and he put that out on canvas, as we'll see. This is a beautifully colorized photograph of Claude Monet. You notice again, a long life, 86 years. Beginning in the early 1900s, he did notice a visual change. I want to point out parenthetically that it was this painting, L'Impression Soleil Levant, Impression Sunrise of 1873, that led to the term Impressionism. An art critic said that this was not a painting, it was just an impression, and that stuck as the name for the Impressionists. A wag back then said that Impressionism was nothing more than a bunch of old men and women who painted with cataracts. Monet, like Mary Cassatt and Daumier, did paint all their lives, like Titian as well. And indeed, he did develop cataracts later in life. Monet was famous for looking at the same area or image. Here we see the Rouen Cathedral. He did haystacks, he did poplars at different times of day, at different times of year, catching the reflection of sunlight and trying to capture those moments, different times of day, different meteorological conditions in his painting. Cézanne said of Monet that Monet is only an eye, but what an eye. After Monet became famous, and indeed he became famous, he bought some property northwest of Paris in Giverny. And as he was fixing his backyard, if you will, there was a pond there, and he built this Japanese bridge over the pond. This is a photograph, not a painting, but he started painting that image. He started painting what he saw, the Japanese bridge. And as you can see, over the years, his painting of the Japanese bridge and the lily pond becomes more drippy, more abstract. I have claimed that Claude Monet presaged Jackson Pollock by at least 30, 35 years. And as we can see here, this is a Japanese bridge painting later in his career that it really, if you didn't know it was a Japanese bridge, you might have a hard time saying to me what it is that we're looking at. It's an incredibly abstract painting, and also, like with Daumier and like with Titian, there's a brunescence to the palette. We can see that even more dramatically here in the 1921 Japanese bridge at the Musée Marmottan. So over the 20 years that he was painting the Japanese bridge, you can see that the palette changed and became much more brunescent, less defined, more abstract, but remarkable in its own way. We would not have these late paintings had he not had cataracts. My dear friend and colleague Mike Marmer at Stanford University, who's written two incredible books with Jim Raven, The Eye of the Artist and The Artist's Vision, two beautiful books. Mosby printed the first one, and one of the New York publishers did the second book that they wrote, and then both of these books are absolutely incredible. Abrams did the second publication. So Mike took photographs of the Japanese bridge. This is the bridge photograph. Then he did the photographs through a 20/50 cataract that was removed, and through a denser cataract that was removed to show you the brunescence and the change. This is an important painting for us to look at. This is 1922. This is the house in the Roses Garden. Again, that brunescent palette. Lots of dark browns, lots of reds, not many blues and reds. But we have from his correspondence this chronology that he did start seeing problems as early as 1900. In 1913, he sees Richard Liebreich in London, who recommends new glasses and recommends cataract surgery. Monet demurs. He says that his colors are muddy and his colors don't have the same intensity. By 1915, so let's see, Monet was born in 1840. So at 75 years of age, Monet has these cataracts. We know that from Liebreich's notes. Monet starts to label the tubes of paint to ensure correct colors and strict order of colors on the palette. And he also complains of night glare and glare in bright lights. He knew by 1919, as we just learned, of Daumier's and Mary Cassatt's unsuccessful cataract surgeries. So he delayed his cataract surgery even more, writing to his good friend, President Clemenceau, from whom, by the way, he received the commission to do what we now know as, of course, the great lily pad, the Nymphaeus lily pad series that is at the Orangerie in Paris. At the time, in 1922, he said to Clemenceau, his friend, "I wish to profit from what little remains of my vision to complete my work. Today, I'm almost blind and have to renounce my work completely." He visits Professor Charles Coutela in Paris in 1922, still refusing surgery. Coutela gives him mydriatic drops to dilate his pupils. And for a few months, Monet is extremely happy because, of course, with dilated pupils, he can get a little more light in the periphery of his cataractus lenses. In 1923, he sees Coutela again, at which time his right eye was light perception. His left eye was 2200. He undergoes cataract surgery in the right eye, topical cocaine, 1 stitch. He was in sandbags. He left the hospital prematurely because he couldn't stand being in sandbags for a few days. And so I just want to mention that the operation was actually a two-stage procedure. He had a sector iridectomy first, and then the cataract, which was almost Morgagnian probably at the time, was removed 2 weeks later. Topical cocaine, as I mentioned, one stitch and sandbags. He developed a posterior capsule pacification, which Cutella lanced at the bedside with a Discision needle, D-I-S-C-I-S-S-I-O-N needle. And ultimately, the visual acuity improved with a +10, +4 axis 90 lens, which we can see here. That's the amber right lens to 20/30. You can see his glasses on the table there. Because of the anisoconia and anisometropia, the Zeiss Corporation, which made these glasses, did a semi-opaque tint on the unoperated left eye. I want to go back to that 1922 painting, and now you see the same scene of the house in the Rose's Garden a year after the cataract surgery. Notice the change in coloration. Of course, you could say, well, that's stylistic, but we have this correspondence from Monet to Clemenceau in 1924. He writes to Clemenceau, "I see blue, but I don't see red anymore, nor yellow, and this bothers me terribly because I know that these colors exist, because I know that there's a red, a yellow, a green, a particular purple on my palette. I don't see them anymore as I used to see them in the past, but I remember very well how it was like." So we do know that there were changes. So as I said, he got used to the glasses. He got used to that right eye going from light perception to 20/30. His visual palette normalized quite a bit. He was able to finish the Water Lily series that he promised to Clemenceau and the state of France. He died in 1926, never having had his left cataract removed. Let's move on for a few minutes to Goya, and fascinating, and again, another long-lived individual who lived well into his 80s. There's one of his many self-portraits. Goya, pre-1972, pre his 46th year of life, was a very happy painter, a very prolific painter, a painter of sunny disposition, if you will, and also a painter of the royal family. He painted for both Charles IV and Charles V in Spain. But in 1792, abruptly, at the age of 46, he manifested an extraordinary constellation of symptoms and signs, including tinnitus, visual loss, vertigo. He developed a right hemiparesis, a headache. As you might imagine, that would lead to melancholia and depression, and an abrupt change in his painting style. All of a sudden, those sunny, happy paintings led to these very dark sketches and the black paintings from Los Caprichos. As you can see here, these two paintings are very dark and very disturbing, actually, from Los Caprichos, and the other one was from the Disasters of War, Los Desastres de la Guerra. Those two sets of sketches and engravings were very dark and very scary. The Colossus, which he painted in his house outside of Madrid, La Quinta del Sordo, the House of the Deaf. He recovered his sight, his headache disappeared, but he remained deaf for the rest of his life. Those of you that are art historians will recognize how much he channeled Velázquez. This is Goya's painting of Charles IV, and there's Velázquez's famous manifesto, Las Meninas, where you see the king and queen of Spain back in the back room there, back wall there in that, what we presume to be a mirror. That's Philip IV with his wife, Mariana. So clearly there you have Velázquez in that painting of himself with the royal family. And then you have Goya in the back there with his canvas painting the royal family, very clearly articulating Velázquez. Goya had a second illness in 1819, from which he recovered, thanking here his doctor for saving his life, basically, for the skill and care with which his doctor, Arrieta, saved Goya's life in 1820. So what did Goya have? Well, as you might imagine, when it comes to any artist, of course, the syphilis diagnosis is always proffered, whether it's true or not. There's no evidence that Goya had syphilis. He didn't have any mercury symptoms or signs, and that was what was given to syphilitics back before we had modern day therapy with penicillin. The Vogt-Koyanagi-Harada syndrome has been offered by several authors as a possibility to explain the ocular and acoustic loss, and it's a uveo-otomeningeal syndrome. I've only seen 2 or 3 cases in my career, but I think was VKH. Plumbism or lead poisoning has been also offered because Goya, like many artists, would put the paintbrush in his mouth, and that might have led to lead poisoning. But what Jim Raven thinks, Jim has written a very fine article in the Survey of Ophthalmology. Jim thinks that Goya had the consequences of malaria and the consequences of cinchona poisoning. He had synchonism, which was quinine poisoning. Malaria was endemic on the Iberian Peninsula around the turn of the 1800s. It's very possible that that was the reason for Goya's abrupt changes, and perhaps he developed toxicity to the cinchona bark, which they would bring in from Peru to Spain to treat patients with malaria. Interestingly, though, and what's less known is that the very late Goya works, I've noticed, are very brunescent again. And is it possible that could Goya have also had cataracts? Well, certainly someone in his 80s certainly could have had cataracts. Degas gives us another fascinating arc and narrative of visual loss in terms of being someone who does not give up. Degas learned from his great mentor, Ingres, Jean-Auguste Dominique Ingres, to draw lines and more lines and more lines and draw from life. And indeed, Degas was not only a great painter, he was a great draftsman. He was a great drawer of works of art before they were painted. As you know, he liked to paint horses and equestrian. He tried out for the army in the Franco-Prussian War and failed entrance to the army. He had a cousin who was blind with a genetic eye disease. But instead of giving up painting, he went from oils to pastels to sculpture to photographies. There we have early Degas. There's a painting of his cousin, Estelle Mousson Degas. Professor Landolt, from which we have the Landolt C's, examined him in 1891 and said that he was, quote, blind in his right eye and had a scotoma in his left eye, but did not give a diagnosis. I think he was too young for cataracts. He probably had some kind of optic neuropathy, or more likely a retinopathy of some sort. Leber's hereditary optic neuropathy has been offered, but there's absolutely no proof for any specific disease of the back of the eye, either retinal or optic nerve. So you can see, we see Degas' changes over his life. So he goes from oils to pastel, because pastels are easier to paint than oil. They don't require as fine work on the edges as pastels do. So Degas, instead of giving up his genius, changes the media in which he's working. He goes from oil to pastels. As you can see here, pastels in the late 1800s. Then he started working in sculpture. He did wax sculptures, which were then made into bronze by the Hebrard foundry. He didn't do the bronzes himself. They were made from his wax templates. But then instead of giving up his life work as an artist, because his visual loss made it impossible for him to paint, he switched to photography. Phenomenal. He went from oils to pastels to sculpture to photography, not clearly in an arc that's one-to-one, but indeed he did transition that. The Metropolitan Museum of Art had a phenomenal show in the late 90s called Degas Photographer, where you can see dozens of his photographs at the end of his life, where he used the camera as his paintbrush. And you can see some examples of his gelatin dry print negatives here from the late 1890s. Vincent Van Gogh is another interesting question. Is it style or is it substance? We know Van Gogh, the great painter, he painted only for the last 5 years of his life and left over 700 paintings, selling only 2. It's not true that he sold none. He sold 2 paintings during his life. You know that he had that altercation with Paul Gauguin, and whether Gauguin cut his ear off or whether Van Gogh severed his own ear, nobody seems to know. The consensus is that he probably severed his own left ear. That's his left ear because he's doing self-portraits in a non-reversing mirror, and so therefore that's his left ear. But one thing we notice about Van Gogh is the predominance of yellow in his painting. Gauguin said that Van Gogh loved yellow. He loved this good Vincent, loved yellow, this painter from Holland, those glimmers of sunlight rekindling his soul, this painter who abhorred the fog that needed the warmth of yellow. Yellow, of course, is catalyzed in our photoreceptors somewhere around 580 nanometers between the M cones and the L cones. As you know, if you paint with pigments, everything sort of gets to be a muddy brown in the middle. But if you paint with colors of light, optical colors of light, which was George Seurat's thesis, and that's a whole different discussion that I go into in the academy course, but there's no time this evening. The spectral colors or the visible spectrum, of course, add to white. So what about that yellow question with Van Gogh? Here at Yale, we have that wonderful painting, The Night Café, Le Café de Nuit, the decoration for the Yellow House. It certainly is an extraordinary amount of yellow. Is the preponderance of yellow, 40% of his paintings containing yellow, is that from xanthopsia of some sort, or is it his style? There you see Van Gogh's own comments about the white clothing of the cafe owner, keeping watch in a corner of the furnace, becoming lemon yellow and luminous green. Van Gogh was known to have manic depressive illness. Whether it was bipolar 1 or 2 has been debated. Bipolar 1 would require at least one full manic episode. He may have had temporal epilepsy and certainly was prone to drinking a lot of alcohol. We'll see that in a second. But the question arises as to whether he had digitalis toxicity or some other condition like Meniere's disease or acute intermittent porphyria. His two paintings of his doctor, Dr. Gachet, and one of them, of course, at the time it was sold, was the most expensive painting sold in the world, $90 million plus the buyer's premium. You see the foxglove there, but don't forget Gachet was a homeopath, so it's impossible for Gachet to have given Van Gogh enough digitalis to have caused digoxin-related xanthopsia. What about Thujon? Well, he certainly was, he frequented the cafes of Paris at 4 in the afternoon with his friends, Mallarmé and Baudelaire. They drank a lot of absinthe. In those days, the absinthe concentrations were not standardized like they are now that you can redo absinthe, but today absinthe doesn't have any Thujon in it. Thujon comes from various sources. Artemisia, the Thuja arborvitae can contain Thujon. And Thujon's functional side groups, although they're a bit different from those of tetrahydrocannabinol in marijuana, they do bind to similar endocannabinoid receptors. So the question has been raised, could Van Gogh have had Thujon-related problems, and that would explain perhaps his hallucinatory paintings. Again, it's thought now that the Thujon concentrations, even in the absinthe by Pernod back in the 1880s, was so small or was so low that that was not the reason. So the consensus today for Van Gogh's ailments were a manic depressive illness, perhaps bipolar 1, a personality disorder with borderline features, visual hallucinations and auditory hallucinations and pulsating lights, but not related to any chemical toxicity, neither digitalis nor Thujon. So therefore his xanthopsia was really not xanthopsia, it was yellow because he loved that color. Edvard Munch helps us, relates to us as ophthalmologists. You know his famous painting, The Scream. He relates to us as ophthalmologists, not because of the scream so much, but because he developed a very large vitreous hemorrhage with floaters in 1930. And he painted his floaters very, very, very compellingly. Here's his floaters. He saw the floater, this enormous floater in one of his eyes, as a bird, as a large bird with dark wings. And we see Munch's disturbed vision as a function of his huge floater. Briefly, Georgia O'Keeffe, the mother of American modernism. Many of you know her dynamic, extraordinary paintings. They are immense, they are compelling, they have a sensual quality to them. And as Georgia O'Keeffe kept going in her artistic narrative, even her artistic palette became duller and browner, so that by the 1970s, she stopped painting altogether. But like Degas, she did not give up her journey. Like Monet, she did not give up her journey. O'Keeffe just changed the media in which she worked in. She developed age-related macular degeneration, and we have those records both from her New York City ophthalmologist and her ophthalmologist in New Mexico. She changed from painting and drawing to pottery. So again, another artistic genius who did not give up her artistic desire and her artistic passion, but she just changed she changed the medium in which she worked. Chuck Close, who died a few months ago, is another extraordinary artist who had prosopagnosia from birth, facial blindness. And in 1948, at the age of 8, he had a spinal artery occlusion. He became a quadriplegic, did not give up his brilliant genius. He just changed the way he was going to do his art. He would do these immense photographs, and then he would pixelate the photographs in an optical sense, sort of like a George Seurat sense, if you will, in that each of these pixels individually has a bit of a whitish background. This is Seurat from a picture I took in Chicago at the Grand Jatte painting, the manifesto of George Seurat. You can see how Seurat placed paint blobs next to one another. Similarly, Chuck Close did that, so that these individual pixels, this is Seurat, and this is Chuck Close, give us the image. And a couple of days ago, this is my last artist, I found out about Peter Eckert. It's an extraordinary story. Peter Eckert, who was born in 1972 and is still with us, is a contemporary blind light painting photographer. He creates images using sound, touch, and memory. He was trained in sculpture at Industrial Design and developed progressive pigmentary retinopathy. And I love the quote that he says here in his paintings. He says, "What I get out of taking photographs," so Eckert doesn't paint or do sculpture anymore, he does photographs. And he does a brilliant type of photography where in taking the photographs, it's the event, not the picture. I do large prints to get sighted people thinking. Talking with people in galleries builds a bridge between my mind's eye and their vision of my work. Occasionally, people refuse to believe I am blind. I'm a visual person. I just can't see. Marcel Proust reminds us that the voyage of discovery is not in seeking new landscapes, but in having new eyes. And Hippocrates reminds us that wherever the art of medicine is loved, there is also the love of humanity. So I thank you for listening to my talk. And we're now going to go into the ophthalmology part of the talk, although I think there was some ophthalmology in my talk. So I want to mention one other thing. The full biographies of all of our wonderful speakers this evening, tomorrow, and Saturday, the full bios are in your agenda. If you go to our website, and Mark Langenham, can you please put the website up on the chat box? I don't have time. We don't have time to do Q&As tonight, unfortunately. I know that there's going to be questions in the chat box. I will leave my email address. You can email me privately and I will answer questions from my talk. But I want to move on because we are already 3 minutes behind schedule. And to introduce our two next speakers from Yale University, Dr. Richard Martinello and Dr. Mark Russo. Dr. Martinello is an associate professor of medicine and pediatrics, infectious disease at Yale School of Medicine and medical director of the infection prevention department at Yale New Haven Health. He researches the prevention of healthcare-associated infections and the epidemiology of respiratory viruses. I really enjoyed what Dr. Martinello wrote in his biography. The world of bacteria, virus, and fungi is fascinating. Each microbe is its own character with its own personality and behavior. Improving our understanding of these microbes helps us to better prevent infections and identify and treat infections where they occur. Mark Russo is professor of medicine at Yale Medical School, where he directs the occupational health services at Yale New Haven Hospital. He graduated from Dartmouth College. He's a Fulbright scholar. He got his medical degree at UCSF in San Francisco, his public health degree in internal medicine residency and occupational and environmental medicine fellowship at Yale. Joined the faculty in 1993, where he is, as I mentioned, a professor of medicine, and is interested in the occupational medicine of health workers and is active nationally in guidance, development, and educational programs to enhance the safety of medical centers. It's my pleasure to introduce Dr. Richard Martinello and Dr. Mark Russo, who will co-teach our next talk, COVID vaccination, treatment, prevention of transmission in the office setting. Richard and Mark, thank you so much for joining us.
Thank you so much, and thank you for that wonderful talk. I think Rick is going to put up our slides. So we'll seek to just provide a bit of an update. Whenever you do a COVID talk, if it's been more than 3 days since your last talk, everything needs to be updated. So we did our best. Next slide, please. So this is where we are. These were Tuesday's statistics: 62 million cases across the country, 839,000 deaths. Of course, the cases are a convenience sample. These are folks who chose to get themselves tested. If you look just at the mortality and apply a mortality rate of something between 0.6 and 1.2%, which is now perhaps higher than the Omicron mortality rate, you get, of course, a higher estimate of actual cases. And given what has gone on with Omicron, that estimate may actually be even higher because we probably would need to divide by a lower mortality rate. In Connecticut, a little over 600,000 cases, about 9,400 deaths. Again, those numbers may underestimate the actual tallies. Next slide. Next slide, Rick. Thanks. I'm not going to go into a tremendous amount of detail. Everyone here knows all of the infrastructures that have had to be built up over the last couple of years, but the hundreds of thousands of tests we now do, the hundreds of thousands of calls we have fielded, mass vaccinations been active throughout the state. We have had to toggle back and forth over the course of the epidemic between containment, where we regard exposures as being exceptions and we chase down every one of them with contact tracing, to mitigation, where we regard exposures as happening so frequently that we can no longer contact trace them. So as we have tried to keep our workforce as safe as possible, there's really been sort of daily attention to these, kind of shifting sands. We have on a number of occasions made the decision to exceed what the guidance was. And I think probably that was the right thing to do. While we could have defaulted to face masks for many months during the early part of the epidemic while treating COVID patients, we actually, with the help of our supply chain group, were able to keep folks in respirators, and we have continued to do that throughout. On a number of occasions, we've exceeded isolation periods. We're actually doing that now. We could, under contingency guidance, be sending folks back after 5 days of isolation without a test. We are sending folks back on day 8. And as you may have seen, there's some recent information, one particular small study out of Japan that suggests with Omicron, the period of viral shedding may be a little longer than a period that would justify sending folks back after just 5 days. So we're continuing to err a little bit on the side of caution there. Next slide. Vaccination, 62% of the US population, about 70 million have also been boosted, and nearly 75% have received at least one dose. And fortunately, in the older age group, 88% are fully vaccinated, and 95% have gotten at least a dose. We're at about 75% of the Connecticut population, and 90% have received at least one dose. Obviously, the ongoing challenges was sort of getting that last group of holdouts vaccinated. And it's interesting, the last time I attended in medicine and took care of COVID patients, and when the ones who came in hadn't been vaccinated, and I asked them why, it wasn't that they were ideologues or rabid anti-vaxxers, but they were folks who, I think there was sort of just enough disinformation out there that it was enough to cause them to just kind of sit at home rather than get up and get to a vaccine clinic and have somebody put a needle in their arm. So obviously still work that we have to do there to get folks vaccinated. Next slide. These are data from the Connecticut Department of Health, and with in the current Omicron wave, we are still seeing about a 3-fold protection from the vaccine over initial infections. And the next slide, Rick, actually shows a 17-fold difference in deaths. So this is a vaccine that protects the people who get vaccinated very well from severe disease. It's not as good as keeping those folks who are vaccinated and get infected from necessarily giving the virus to other individuals. Folks can still transmit, although they're having themselves very mild disease. But again, very good at keeping people from getting really sick. And the data on hospitalizations are about halfway between these two graphs, about an 11 to 12-fold protection against hospitalization. Next slide. I'm going to skip over this one because Rick is going to comment on a slightly more recent version of, is this, okay. Thanks, Rick. So this is, you can, if you look at the blue line below, you can kind of see what our hospital admissions have looked like. And the little bit of optimism is from, the last few days that we're just beginning to see cases come down a little. We had at one point been over 760 cases across the health system, inpatient cases, and hopefully this is the beginning of things tailing off a little bit. Next slide. Similar admissions, you can see that in terms of actual admissions, we have had a few days that have been higher than at any point in the past. Next slide. So what about boosters? The strongest evidence really for boosters initially was this study out of Israel, where they started boosting fairly early toward the end of July, the folks over the age of 60, and they were able to demonstrate an 11-fold lower infection rate and severe illness 20-fold lower than the non-boosted folks. And that was with about 1 million individuals in Israel. That was reported in the New England Journal in early October. And so we have, of course, proceeded to boosters. Next slide. We have actually mandated boosters now for our healthcare workers. And the initial case, I think, for vaccine mandates was pretty strong, certainly compared to mandates for influenza vaccine. This is a more lethal disease. It spreads more easily. There is a higher proportion of folks with very mild or asymptomatic infection, which of course predisposes them to being out and about in society, infecting other people. The vaccine itself, of course, is better, certainly against the earlier variants, and still quite effective against severe outcomes with Omicron. Next slide. So Omicron, just a couple of comments on that. Everyone has heard it seems to spread more easily, seems to cause slightly more benign disease. It may be 3- to 4-fold more contagious than Delta. And we don't adequately understand yet what comprises that increased transmissibility. A lot of it may be immune escape. And this has been the conclusion of folks also, because the Delta versus Omicron difference is not quite as great among the unvaccinated. Some data have suggested a higher amount of virus released from an infected individual. Not all studies have shown that. So we don't really have consensus on that yet. We don't think that this is something, this is a disease that spreads easily over very long distances. There have been a couple of isolated examples from that, an outbreak in Hong Kong and a couple of others. There is a faster time course, which predisposes to more infectivity, 3 days versus 4 to 5. And there's more of a predisposition for the bronchi rather than the deep lung, which is good because it causes less pulmonary morbidity, fewer intubations, but may also result in more efficient delivery of virus when people cough. We don't know whether there's a lower infectious dose that is required. And certainly the milder clinical illness may predispose to enhanced social mixing that can just make it more effectively transmitted in society. Next slide. We've learned a lot over the last almost 2 years. Some of the things we've learned may find their way into longer term guidance. There's been a fair amount of discussion of this down at CDC. We have seen how effectively social distancing and masking took care of influenza last season. It's making a little bit of a comeback this season, but it's certainly not a banner year for flu virus to date. We may find ourselves masking at a lower threshold in healthcare settings, whether or not that's linked to specific patients. And there's also discussion of a mask that may find itself sort of somewhere between a surgical mask and an N95 respirator that requires imposition of the OSHA respirator standard. And there's been a fair amount of discussion about that as well. I think I have one more slide, Rick. A lot of discussion about endemicity, certainly for a long time, folks have accepted that the trend would probably be toward a virus that spread more easily and caused slightly less severe disease. And that's kind of what we're seeing with Omicron, is this sort of the first hint at endemicity. Important to bear in mind that endemicity does not equal benignity. We could, flu is endemic, but it kills 30 to 50,000 people a year in the US. But we may be making our way toward that. Next slide. I think this is where I hand it over to you, Rick.
Yeah, let me make sure my mute is off. So for those of us in Connecticut, but also the surrounding states, we know what we've been experiencing. And of course, in the New York Times, they've been very nicely illustrating and sustaining up-to-date information. And it's been really remarkable to see how quickly Omicron has spread throughout our community. And I think one thing that's very important about what's being shown here, and let me pull up the laser pointer, is the rates of disease that we're seeing in the community just substantially exceed what we experienced, not only the first wave back in March and April of 2020, but also that of last winter. It's just, vast amounts of COVID that's spreading in the community. And while it is, I think there is consensus in the infectious disease community that this is a much more mild illness. Of course, there's still that broad spectrum of severity of disease. And so as Dr. Russo had shown before, and is illustrated here in the New York Times data, that we are experiencing that now with extraordinary workloads for our hospital staff, with the number of COVID patients that are present. And unfortunately, while our hospital numbers are thankfully going down, unfortunately, our ICU numbers are still going up, because we know that those with the most severe disease experience the longest lengths of stay in our hospital. And then we anticipate that over the next number of weeks, we are going to see much more of a substantial rise in deaths that's going to correspond with our rates of hospitalization and ICU stays for those who have COVID. One of the markers that we look at to identify the Omicron variant and differentiate it from the Delta variant is that of what's called an S gene target failure. So we're all familiar with the S gene and the S protein that's on the virus itself. Our PCR diagnostics, many of the platforms that our laboratory uses actually target the PCR primers for that S gene, and in addition to a number of other targets. And so what we find are people who are positive for those other targets, but negative for that S gene. And so we call that an S gene target failure. And we could use that now as a surrogate marker for Omicron itself. And this is data from Yale New Haven Hospital that was performed in Nathan Grubau's lab at the Yale School of Public Health. And what you could see in the black line is the proportion of our COVID isolates that were thought to be Omicron due to the presence of that S gene target failure. And you can see that during the month of December, just rapidly rose here in Connecticut, and now it's over 95%. One thing that's been interesting is it has been at this rate, and the rate of rise has really been the same for our ambulatory patients and in addition to our hospitalized patients. And what you could see in the blue and the gray bars in the background are the actual numbers of samples that are positive for Omicron, and Delta in the gray. And we are still seeing a small amount of Delta, but Omicron has really very much taken over. Nate Grubau has a really terrific Twitter feed. Many people have asked Mark and I how they can receive Nate's data, and actually the best way is through his Twitter feed, and he has nearly daily updates on the data that his lab is producing. The CDC, starting a few months ago, developed some new predictive analytics, and their model is actually a compilation of about 20 different mathematical models that try to predict out over the next 4 weeks where we're headed. And this is their most recent data showing their aggregate model of these models. And the left-hand panel shows you the national data, and this is specifically for hospitalizations. And so we are about here now, and we are anticipating as a country we'll be seeing many more hospitalizations over the next month. Here in Connecticut, as I think our Yale New Haven data is now showing, we are reaching more of what we may consider or anticipate to be a plateau of sorts, where we are expecting to continue to see high levels of hospitalization as Omicron continues to circulate in the community. But hopefully, as Dr. Russo showed, we're starting to see maybe at least at that plateau, maybe even starting to head down in our rates of hospitalizations a bit. To summarize some of what we think with Omicron is that we do know it is spread more person to person more readily, and there are a number of hypotheses that Dr. Russo had presented. We do have consensus, I think, that there is less severity of disease, but of course, when you have a greater volume of disease and a wide spectrum, that explains why we are seeing such a surge in hospitalizations and the need for ICU care. And if we look at the right-hand side of this table, this is where we do have some concerns. We do think our antiviral treatments are going to continue to work, and I'll speak more on that in a few moments. But we have found that with Omicron, it does impact how well some of our earlier monoclonal antibodies work. And specifically, the Regeneron product and also the Bamlanivimab product, we are no longer using, and the FDA actually recommended that once the prevalence of Omicron in the community raises above 10%, recommended stopping the use of those two antibody therapies. And so across our healthcare system, we've done that. We have also seen that there's a decreased effectiveness of our vaccines for the prevention of infection itself. There has been sustained high levels of effectiveness against severe disease and against hospitalizations, but because we've seen less effectiveness against infection itself, that's where the recommendation for the booster has come in to assure that we prevent disease as much as we can. And while we know, as Dr. Russo said, that those who are fully vaccinated can still transmit, the fewer fully vaccinated people who don't get sick, the less transmission we'll have. And so that's part of the logic behind our enthusiasm about boosters, and certainly why we've mandated it across our Yale New Haven health system. This is what I've tried to do is to put together a summary of our guidance on vaccine use. And this was about as simple as I could make it, so there are some details missing. But suffice it to say that we divide vaccination into what we call the primary series and then the boosters. The primary series is what is considered to bring people up to speed and their immunity up to speed to protect them as best possible against the disease and its more severe manifestations. But we do know that over time, the immunity wanes, and that's where the booster dose comes in to return that degree of immunity back to where it needs to be. And we've heard a lot of concern that we are needing these boosters. We're now considering a primary series to be 2 doses. We may consider a primary series to be 3 doses in the future. And I just want to remind the group that for many of the vaccines that we currently use, we could think about our hepatitis B vaccination as an example, where our primary series is those 3 doses. And we know that on occasion, some of our healthcare providers, some of our other individuals may need a booster dose as the years go on. And so our vaccines against COVID are really no different than what we've already have precedent for with other vaccinations. Vaccination is recommended by the CDC for all of those who are 5 years of age and older. For those who are between 5 and 17, it's the Pfizer product that could be used, and the booster should be through that Pfizer product. It is important to note that for those between 5 and 11 years of age, a booster is only recommended if people have an immunocompromising condition or are receiving immunocompromising medications. For those who are 18 years of age and older, any of the 3 vaccines that we have authorized and licensed for use in the US can be used, and those vaccines can also be used to provide a booster. I think it's important to note, and something that COVID in our experience has really taught us, is I think we need to be more precise about what we expect out of our vaccines. For decades in the past, we've traditionally looked at vaccine effectiveness being defined as the ability for that vaccine to prevent an infection with the pathogen it's protecting you against. And we know that for many of our vaccines, and flu vaccine is an excellent example, our vaccines are imperfect. It's been estimated that for the flu vaccine, when we look at the effectiveness to prevent infection over a course of many years, that on average, it's about 59% effective in preventing disease. But similar to the COVID vaccine, the flu vaccination has much better effectiveness to prevent severe disease, and in particular to prevent hospitalization and to prevent death due to that illness. And so when we look at the COVID vaccinations, while we see waning effectiveness over time for the prevention of disease, it is still an outstanding vaccines that we have available to us, because we do know that they remain highly effective in the prevention of severe disease and the prevention of death due to COVID. We've heard a lot of criticisms about these vaccines, being rolled out so quickly and not being sufficiently studied. But something I think is true is that these vaccines have been more intensively studied than any other vaccine that we routinely use in our practice. And with that, we've gained just an enormous amount of understanding of the safety of the 3 vaccines that we're using here in the United States. We do look forward to mRNA technology being adapted to other vaccines. I think the only other thing I'll say about vaccines is in regards to mandates. We do know that they are certainly acceptable. We see Yale University, in addition to the Allen Haven Health System, applying them. I do understand that the Supreme Court is ruling on this today, so I look forward to catching up with some of the news and seeing what they did have to say. We do have some new medications that are available for treatment and prevention in the ambulatory setting. And I want to take a few moments to go through these. Let me start off with the antivirals. One is Malnupirovir, and this is a product from Merck. It's an oral 5-day regimen, and this medication is a nucleoside analog. And we use many other medications which are nucleoside analogs, such as acyclovir, for example. However, the mechanism of this medication is a little bit different from other nucleoside analogs that we use. This one actually inhibits viral replication by forcing the virus, as it's attempting to replicate, to create a lot of errors in its reproduced genetic material. And because of all the errors that are present, that it generates new virus, but that virus is unable to further reproduce because it's full of so many mutations. It has been shown that this medication can decrease the severity of disease, and there's a significant decrement in the number of individuals who require further medical care. And it's also been shown to be show significant benefit in the decreased risk for death due to COVID. However, there is caution in how we use this medication because its mechanism forces the virus into an increased rate of mutagenesis. There is a theoretical concern for women who are of childbearing age, and certainly those who are pregnant, but also concerns been raised for men who are looking to bear a child within the forthcoming 3 months. And so we do want to be cautious in the use of this medication for those populations. The FDA, in their emergency use authorization, does recognize that this medication can be used for women who are pregnant, but they do guide that counseling should occur, and so there should be both shared decision-making and awareness between the physician and patient of some of these concerns. The reason it was not contraindicated is because this medication is short-lived, and it's taken for such a short period of time, only 5 days. And we do well understand that COVID is a significant risk, not only to the mother who may be ill, but also to her unborn child. The second medication we have available to us is Paxolavid, and this is a combination medication that Pfizer produced. Malnupirovir is a protease inhibitor, and it's combined in oral capsule with ritonavir. And the ritonavir is there for its effect as a cytochrome P450 inhibitor. And so the presence of the ritonavir allows a boosting of the protease inhibitor levels. And this too is authorized under an FDA EUA. It is also an oral 5-day regimen. And it too was found to be highly effective, about 80 to 90% effective in preventing hospitalization and death due to COVID when taken. And it's a very attractive medication with one big caveat. And the caveat is that since we have ritonavir as part of this medication, there are numerous drug-drug interactions. And so if somebody is receiving a drug that is metabolized through that cytochrome P450 system, this drug is relatively contraindicated for use in that individual. 2 monoclonals that are now available. One is known as Evusheld, and oftentimes mistakenly called Evusheld. And what's unique about this dual monoclonal antibody preparation is that its indication is actually for pre-exposure prophylaxis. And we specifically want to direct its use to individuals who may not have responded well to vaccination and be protected from that, or persons for whom vaccination was contraindicated. And we've seen a very small but significant portion of individuals who may have severe allergic reaction, for example, to the vaccine and be unable to receive it. And so those individuals can get this IV monoclonal antibody, and it will provide them with prolonged protection against COVID. The last monoclonal antibody I wanted to mention is Trovamab, and this too is authorized under an FDA EUA. It's a monoclonal antibody against the spike protein, and what is making it attractive at this point is that it retains effectiveness against the Omicron variant. And so it is a medication that we're using now to treat individuals with lab-proven disease who have mild to moderate illness and are not sick enough yet to be hospitalized due to COVID. For all of these medications at this point, they are actually quite scarce. When we look across our healthcare system, despite the size of our system, we are counting the availability of this medication in the dozens and in the low hundreds. We are anticipating that over the next number of weeks and hopefully months, we will be seeing much better availability of each of these medications. But until that availability changes, we are focusing the use of all 4 of these medications toward individuals who have not only at risk, who are at risk for severe disease. Our isolation, our quarantine policies, unfortunately, are very complex. We do try to stay aligned with the guidance from the CDC. Those recommendations are complex, and we've actually tried to simplify them to some extent. We do allow and recommend that for our patients who are in the community who develop COVID, there we do align with CDC. But because, as Dr. Russo was saying earlier, we are concerned about more prolonged shedding, especially for our patients who may have a lot of comorbidities, and then also for our healthcare personnel who are interacting with our patients, we do require more prolonged periods of isolation, 7 days for our healthcare staff, and then 10 days for patients as they come back into our system. We do require more prolonged isolation for patients who experience severe disease, because we know they may shed the virus for a longer period of time, and those who are immunocompromised. Thankfully, our criteria for quarantine is a little bit more simple, but it still is complex enough that this was about the most simple illustration of it that I could devise here. We do look as to whether or not our patients are up to date or not up to date in their vaccination. And the definition of up to date includes receipt of booster vaccination. And we do recommend for the general public that they be quarantined for 5 days if they are not up to date with their vaccination. It's important to note for our healthcare staff, even if they are not up to date with their vaccination, we do not require them to quarantine. But if they're not up to date with their vaccination, we do require that they be tested twice, but we allow them to work if they are asymptomatic. We always take a layered approach to how we focus on personal protective equipment. First and foremost, vaccination is really a keystone of how we help to protect our workforce, and we hope our patients follow with that. When patients present who may have symptoms concerning for COVID, we try to identify them as quickly as possible and make sure we're isolating them, making sure we're caring for them in a way that we're protecting our staff and protecting our other patients. Thankfully, we have amazing availability of testing, so that helps to support this. We know that even though the virus that causes COVID is spread by small particle aerosols and other respiratory droplets, that those aerosols are at greatest density around the contagious person. And so physical distancing still is thought to be quite helpful. And to help rid the environment of those aerosols, ventilation is especially important. Something we've done across our Yale New Haven health system is that in areas where we care for patients who require isolation for COVID, but we do not have negative pressure rooms available, we have deployed hundreds of portable HEPA air filters to help facilitate ridding the air that's in that environment of any infectious virus. And then, of course, personal protective equipment. And there is a lot of discussion at this point as to whether or not we should be more extensively using respirators. The approach we take in Yale New Haven Health is that if we have any of our staff interacting with a patient where there is concern that they may be contagious, our standard is to use a respirator. For all other interactions, a face mask is our baseline recommendation. I also want to note that at this point while we're seeing so much COVID in the community and also within our healthcare system, it is standard for us to use eye protection to prevent any respiratory droplets from entering in our staff's eyes. And so we use that eye protection for all patient interactions. And I will go ahead and stop there. And if time permits, Dr. Russo and I would be very pleased to take any questions.
Thank you so much, Mark and Richard. Phenomenal talk, comprehensive and thorough. Unfortunately, we're already 10 minutes behind, so I'm going to ask both of you to put, if you can or will, can you put your email addresses in the chat box? There were several important questions about Omicron boosters, which we heard that Pfizer may be delivering, I think, later in the spring, if I'm not mistaken, but there were several other questions in the chat box. Could you answer them to everyone, if you wouldn't mind, on the chat box, and leave your email addresses, if that's okay, so that our attendees can contact you directly. Thank you so much for sharing your expertise with us this evening. We really appreciate it. And please stay on for our evening talks if you wish. So I really have the great pleasure of inviting and introducing our next speaker, my good friend, John Shepard. His career is so extraordinary that I don't even know where to begin to announce his bio and CV, and his full bio and CV, as are all the bios and CVs in full in your agenda. I just want to say that among the many things and many hats that John wears, he is a professor professor of microbiology, ophthalmology, and molecular biology at Eastern Virginia Medical School, and research director of the ophthalmology residency program there. He's also the COO of IRX Research, which is a pharmaceutical development company, and founder of ProvisionNetwork.com, a major buying group for ophthalmologists and optometrists. John came after me a couple of years at the Proctor Foundation, where he spent 2.5 years in corneal ocular surface and uveitis. And as many of you know, who are involved in clinical trials or who study clinical trials, John is arguably one of the world's most prolific and most important clinical investigators. He has been a PI in over 100 clinical trials for major pharmaceutical companies. He's on the medical advisory board of over 60 pharmaceutical companies, and has authored over 120 peer-reviewed articles. He's the chief medical editor for Medscape Ophthalmology. And also, I think it's quite important to mention all the work that he's done in Virginia. His group, Virginia Eye Consultants, have won several national awards. They were one of 20 fastest growing businesses in Eastern Virginia. They were U.S. Chamber of Commerce national finalist as the best business in the area and in the Southeast United States. John also directs the Thomas R. Lee Center for Ocular Pharmacology, where he conducts clinical trials. I could go on, but it is my great pleasure at this time to introduce John Shepard, who will give us a talk on the state-of-the-art ocular surface disease management to enhance surgical outcomes. John, welcome to CSEP and the New York State Ophthalmologic Society.
Well, thank you for that incredible introduction. I trust that the screen sharing is functioning, and wow, what an incredible armamentarium of knowledge we have here tonight. I trust that things are moving forward nicely for everyone and that we can get you all to dinner on time with a great presentation coming up. The current situation in COVID, in eye care, in ophthalmology, ocular surface, implantation, prostheses, is so exciting and so much in flux that I would caution you to listen to this lecture in a year and see that 50% of the material has changed. But if we're eye surgeons, we have to understand that virtually everything we do affects the ocular surface, and that ocular surface disease is highly prevalent in virtually all of our surgery candidates. So if we want to do premium lenses of any variety, we must marry ourselves not only to understanding the lenses, but managing the ocular surface, managing the retina, and understanding the compatibility of patients with each modality. And we must have zero tolerance for a wide variety of ocular surface conditions and ocular conditions prior to various types of ocular surgery, or we get mad patients who have hyperopic or myopic surprises and bad toricity, as an example. For instance, we don't want to miss keratoconus. I try to do cross-linking at least 6 months before a keratoconic procedure for lenticular refractive surgery. We must optimize the ocular surface, remembering that Dick Thoft named this entity several decades ago in the last century, and that this orchestra of the ocular surface performs only as well as its worst performing member. I use the term dry eye disease. I'm not really enamored with these others, and it may be less scientific, but doctors, patients, insurers all recognize this name. And you must commit to being excellent in ocular surface disease, that is dry eye disease, because you have no choice if you want to be an ophthalmic surgeon of any variety. 2 companies will give you certification as a dry eye center of excellence if you so choose. And in our practice, marketing dry eye is just as important as marketing cataracts. They go hand in hand. Recruit cataract patients, you have a dry eye clinic, and vice versa. And yet, dealing with ocular surface disease and dry eye may draw objections. My biggest solution is to engage physician extenders. PAs, ODs, scribes, movers, counselors, all get these patients taken care of so the doctor only does what only the doctor can do. make decisions in the clinic, evaluate new patients, and perform surgery. So you need to do targeted therapy. You can look at the lids. These are very important. Most dry eyes associated with lid disease. Patients like these pictures. They understand this DMI modality, and they like to see that they've stabilized any loss they have. Osmolarity is the primary marker of dry eye disease. 308 is the borderline of normal, but you may have horrible disease or subtle disease depending on changes in osmolarity, which I use to biomark therapeutic intervention. Similarly, the matrix metalloprotease 9 test can be done in your clinic within 10 to 15 minutes. Training your staff is essential, and it guides my therapy towards perhaps more aggressive anti-inflammatory topical treatments. Here we see a youngster with an acute bilateral teary conjunctivitis. Get him in and out of your clinic. We all know that some patients with adenovirus may develop severe cicatricial lid and conjunctival disease, as well as debilitating glare subepithelial scarring disease. And I know a dozen physicians, mostly pediatricians, who are now out of work because of the sequelae of adenovirus. It is key to avoid transmission in your practice. That's why most of the tests we do actually take place with employees who may have been exposed. So we can mark dry eye. With these immunodiagnostics, we can mark adenovirus. And I always remind my students to look for pre-auricular lymphadenopathy, an outstanding way to differentiate acute viral disease from bacterial or toxic disease. Palpate and document. The treatment is quite simple: isolation and ganciclovir gel as a treatment. Adenovirus type 8 is exquisitely sensitive to this off-label use, and supportive therapy. And then for maintenance, if there's a risk of scarring, lodiprednol is excellent. You don't want a patient coming out of your clinic and a week later saying, I got pink eye at Dr. Jones' practice. So we can do diagnostics in our clinic. After all, allergy is probably the most prevalent ocular surface disease and interdigitates in about 30 million patients with dry eye disease. You can do the skin test, you can bill for it, they don't have to go see their internist or an allergy specialist. So once we've characterized allergy, meibomian gland disease, dry eye, hyposecretion, hypoevaporation, hyperevaporation, we can get the 4 pillars of therapy on board. Let's look at tear supply, tears, plugs. Control the MGD so you control the evaporative loss, and consider trigeminal afferent stimulation. Have these retails available in your clinic. Have an online website to sell these to your patients conveniently. They are very appreciative. Use a good mask, not a lousy mask, and use punctal occlusion in all its varieties. I'm not a big fan now of the plastic plugs because a plurality of patients have irritation from the tip, defeating the purpose of the implantation. Instead, we use temporary plugs unless the Schirmer's is consistently and expected to be so below 4, in which case we will do permanent inferior punctal occlusion. Thermal pulsation and its cousins are very important in the treatment of meibomian gland disease. The literature supports this in a wide variety of patient populations, all of whom may become cataract patients. And the Blefex is an excellent debridement material for eviscerating the caps on the top of the meibomian glands and allowing a much more effective expression with other therapies. A watered down one surface heating agent is the Miboflow, which is good for patients who have cost sensitivity and still need to have their meibomian glands opened. The tear care similarly applies external heat and provides an excretion agent, a compression agent, to manually extirpate all of the meibomian secretions, and generally requires more physician time to do so, although PAs, ODs, and even trained technicians are very good at this expression technique. The pilot and the approval data are excellent. Retreatment restores an excellent ocular surface at about 6 or 7 months, and we see that the OSDI improves consistently with this treatment. At our clinic, we have a wide variety of packages with different combinations, and this is well received by patients, many of whom may want to take something home with them as well. IPL is great for lightly pigmented patients, especially my rosacea patients, and can be applied also by a technician and works beautifully in combination with topical medications. This therapy is best delivered by the Luminous company, but some competitors are rising. The Alcon iLux is an excellent personalized application that, again, a technician or a provider can apply and gets the heat down and the compression down in the same step. You can watch the device through the magnifying lens and apply it to all 4 lids simultaneously in a series, taking about 20 minutes of your time or the technician's time. And you can see it is highly digitally oriented and minimally uncomfortable. I liken these to spa therapies for the eyelids. And we see that the iLux has excellent data and allows a decrease in symptomatology, as well as an improved meibomian gland score at an early interval, thus preparing patients for surgical intervention, contact lens use, or simply a more normalized lifestyle. This even improves the tear film breakup time. At the spearhead, we see ELM, the eye lipid mobilizer, which employs resonant frequency stimulation, which is a multimodal mechanism with heat, liquefaction, and mobilization. This comes from a startup in California and shows us that non-Newtonian fluid dynamics improve the extirpation of high viscosity fluid and decrease the shear values, much as you would with tomato ketchup. You squeeze slowly, not too quickly, or everything comes out at once. A great analogy. A new site will allow you to actually sell a home or office device, depending on your choice and the patient's choice, that can be applied like a toothbrush to the eyelids. And this therapy is likened to brushing teeth, washing the face, and cleaning the lids. Lid hygiene is very important for my patients and is done with devices, with warm compresses, not wet, dirty rags full of fungi, of course. And it can be also performed by patients who use lid scrubs as well. The neurostimulatory implant was designed to increase lacrimal outflow. And if you stimulate this system with either a slow randomized low voltage current from the old Tear True mechanism from Allergan, which was taken off the market, or now from nasal varenicline, which is a nicotinic drug from Oyster Point, you can see that not only aqueous tears, but also meibomian tears are produced as rheolin glands along the lid margin are actually activated by the parasympathetic stimulation. So you get an upregulation of all the lacrimal functional units from parasympathetic stimulation. Tyrvaya is just recently approved and is applied in a lateral way to the anterior nares, BID. And this shows you that the stimulation to the ocular surface from the environment comes 2/3 from the cornea and conjunctival epithelium, but 1/3 from the nasal epithelium, which is the only stimulus while the patient is sleeping with the eye closed. So this new method is outstanding for patients with tremors who like to wear makeup, who have neck difficulties, and who have multiple medication challenges. We found it excellent. You have to tell them they're going to sneeze. That's part of the deal. So we have anti-inflammatory, we have anticollagenylytic, we have parasympathetic stimulatory, we have biologics with nerve growth factor, amniotic membrane. We use a lot of hypochlorous acid and some amniotic derivatives. So this pipeline is very exciting and is adding to the marketplace every year. I'll point out the new vehicle from Novaliq and the new MOA from Aldera with the RASP inhibitors, which will soon be on the market as well. Traditionally, we would induce with lodiprednol and artificial tears. We would add cyclosporin and then wean from steroids. This is an excellent induction maintenance therapy. And we see that so many of the FDA-approved drugs, all 4 of them, are anti-inflammatory. They act upon T cells and the immunologic handshake with lifitegrast, with, again, cyclosporin for signs only, and now signs and symptoms with Isuvis, which is an approved QID 2-week therapy for acute episodic dry eye using the Amplify technology, this mucus penetrating particle, which allows better penetration and higher concentrations in ocular surface membrane materials. If you have a toxic patient with severe advanced disease, such as Sjogren's, you may investigate oxervate, as we are at this time for Dompe, or you may apply a biologic membrane. Biotissue is moving its procara lens to the biologic status required by the FDA. And this lens centers well, especially with steri-strip tapes to the eyelids, and allows the patient excellent comfort if they're neurotrophic. If they have swollen lids, they may not like this. But I find this particular cryopreserved modality vastly superior to dried amniotic membrane, which does not contain the biologic HCHA TFX3, which provides that amniotic boost to regeneration, healing, and anti-scarring. We see this derivative is truly natural. These patients are highly screened for the membranes. And we compare the ProCare to the regular bandage contact lens and see that there are so many more advantages, including lack of hypoxia that we see with a soft contact lens. That problem can be solved with a tinted contact lens, a hard lens like a RGP on your left, but more importantly, a scleral lens on your right, which produces this chamber of tears and therefore oxygen and even medications on the irregular surface of an eye. Scleral lenses have become universally adapted. We have a dozen optometrists in our region who fit these extremely well and effectively for our serious ocular surface patients, or you can refer to a pros clinic where a custom fitting with each eye is performed on an academic basis. The choices are many. The access is important for your patients. Autologous serum tears are used by a wide variety of clinics, can be farmed out to a compounding pharmacy with the patient's blood. Many corneal clinicians find this to be very effective. Many patients are married to this treatment and truly prize the beneficial effects, as they might also with Regenerise amniotic membrane derivative. Here we see a Mackie stage 2 patient with a PED and dry eye, and the central defect is always central because of the centripetal migration that Dick Thoth described from the limbal stem cells. The weakest, oldest, least adherent cells are right on the visual axis, the tragic irony of neurotrophic disease. And Dompe recently approved in Europe and a year later in the United States, Synedrimin, which is a biologic. It's identical to human nerve growth factor. It treats neurotrophic keratitis, stage 1 through 3, indicated for stage 2 and 3, and provides excellent healing with 6 times a day, 8 weeks of therapy. We found this very useful in our desperate patients, and most of them go into remission for up to a year. There are sustained release delivery devices that should be available through your clinic. Lacrosert has been around for a century. Dextenza is approving products now with a steroid implant, and this hydroxypropyl cellulose may eventually become a delivery system, now marketed by Bausch & Lomb. Dextenza is a product that we find from Ocular Therapeutics that releases any number of drugs, including a low dose 6 to 12 week steroid for patients who actually have dry eye. And you can see this because it's fluorescein tagged in the punctum, and you can decide when it will dissolve. These can be designed to last up to 90 days in most patients. We see the data in a preliminary trial was quite favorable in terms of improvement in the signs and symptoms of dry eye. Another company makes a plastic container that goes into the inferior punctum, and Maddie's drugs can provide anything from dexamethasone to travoprost and Pafinac and other dry eye active medications. Nutritionally, we look at supplementation as well as environmental regulation for the patient who's better educated. We know that omegas work for a wide variety of diseases, and we've done trials with Hydro Eye, which is a commercially prepared DHA, EPA, GLA preparation taken 2 pills BID. We showed that the OSDI improved in these patients, and with labeling of the ocular surface impression cytology through the Flugfelder lab, we showed that patients untreated had worsening of the inflammatory cells on their ocular surface, whereas the immunotherapy provided by this nutritional stabilized the inflammation on the ocular surface over a 24-week time period. Similarly, another commercial preparation from PRN uses oral reesterified omega-3s that improve signs and symptoms in 105 patients in a prospective randomized multi-center trial with a number of biomarkers successfully documenting this as a viable, systemic, nutritional, almost side effect-free intervention. We're all devolving. We know that nutrition is horrible in this country. We know that the single anti-aging therapy that actually works is caloric restriction. This is hard to do. It's created quite a lexicon of literature documented by the biosphere. which locked people up and showed that they showed much less insulin resistance, much improved DNA repair, and a number of other biologically life-extending features from caloric restriction enforced in that biosphere. We also know that good diets from the blue zones have improved longevity, inflammation, and we showed that these people are calmer. They take their time. They don't smoke or drink too much alcohol. They eat meals of seafood, fruits, and vegetables. They snack on nuts. And this lifestyle is truly beneficial to my eye patients who have inflammatory ocular surface or uveitic disease. And we also use a simple diet from Barry Sears, a PhD biochemist who invented the zone diet and shows that the zone has the lowest carbohydrate and the highest good fat content of any of the recommended diets. I recommend this book to several patients every day. And we can modify the environment intelligently and educate our patients about humidification, particularly at the computer. And we tell our patients they have a dry eye before surgery. Before they have surgery, you document the floaters and the maculopathy and the diabetes and any pre-existing uveitis, especially being very careful not to put a premium lens in a patient who has any type of compromise in the front or the back of the eye. It's your fault if you don't document it ahead of time. And Mike Lemp told us that indeed 86% of patients with dry eye have an MGD component, thus a wide variety of new drugs about to enter the marketplace in this particular important target. You can use tea tree oil to treat MGD. This is available from BioTissue and a number of other companies, and it targets a wide variety of inflammatory processes on the surface. Azura is working on a cutaneous preparation, selenium disulfide, which is a keratinolytic and increases lipid secretion by the meibomian glands. This will be in market in several years. We look at Novo-3, a drug that will probably be in the market next year, which is a perfluorohexyl octane. This semifluorinated alkane is water-free, preservative-free, doesn't require preservatives, produces a very small, ideally suited 20 microliter drop, which is exactly what the ocular surface holds. In and of itself, it has been shown in several clinical trials to improve dry eye signs and symptoms in patients who have MGD. And these clinical trials are going to lead to approval in the near future. Similarly, this can be a vehicle for other insoluble drugs like cyclosporin. Hypochlorous acid is used in a number of preparations, very much available to the clinician today. And it's a natural surface antioxidant. And experimentally, it is coming from neutrophils who engorge bacteria and kill them. This has anti-biofilm activity. It kills a wide variety of microbes that affect the eye, and many of these are pathogens. But it doesn't change the floral diversity. It just reduces the number of bacteria on the surface by 2 log orders. I use this for all my preoperative patients and all my ocular surface disease patients. And it inactivates lipase better than any other surface preparation, and therefore reduces inflammation from bacterial excretions. There's a number of preparations available, including Avenova, OcuSoft, and a number of other companies. Demodex is fairly common, and it's almost universal to the geriatric population upon whom we operate the most. 9 million Americans, 45% of those 20 million with blepharitis are infected with Demodex, and we've all seen the wonderful videos of these disgusting organisms. But they are very important in terms of lid hygiene. This is a strongly implicated organism in a wide variety of ocular surface disease situations. They basically excrete all sorts of bacteria and toxins onto the ocular surface. And here you see the collarettes and sleeves, so indicative with the eye turned down. In a number of patient groups, this Titan study showed from Tarsus that we have an almost ubiquitous condition in those patients who have ocular surface pathology, and that this has validated safety and efficacy, whereas a number of other interventions do not. So if you look at ex vivo mites extracted from treated and vehicle-treated patients, there's an almost total eradication of mites within 24 hours, 2 years to DA approval, a specific Demodex agent. Finally, the most common ocular surface disease, allergy. Or is it dry eye? Or is it MGD? Or is it all three? Patients often have a combination. And this disease affects at least 35 million people in the United States. Like this little kid who's rubbing, itching is the sine qua non of allergy, as is chemosis. But I encourage you to flip the lid and look at all these findings from the vessels, papillae, scarring that tell you about the activity, the acuteness, and the chronicity of absolutely ubiquitous upper lid allergic disease. And look at the early entropion, just like we see in trachoma. Michael M. told us that about 86% of patients with dry eye have MGD. And the essence of allergy treatment is avoidance. We do allergy testing in the office. We give them silk pillowcases. We keep their fingers out of the eyes, and we use cool stuff on the ocular surface. There's a number of agents available, including prescriptions and OTCs. The newest is cetirizine or Zyrtec drops. I use a ton of Montelukast or Singulair rather than the drying antihistamines, and Flonase is now OTC. You can use a number of topical agents that are available over the counter, but I never use vasoconstrictors. Stick with ketotifen. It's available all over the world. And now you can use Lumify for redness. It doesn't treat the allergy, but it makes the patients happy. You can optimize your practice, do better medicine, better business. We found that the bottom line for the profit and loss statement for society was a 26% cost reduction by treating these diseases early, correctly, and aggressively, and avoiding chronicity. So the patients, the payers, the physicians, and the practices win. Ocular surface disease, dry eye is part of our life. Treatments are changing, but your patients will applaud you for addressing something that others might ignore, particularly on a Friday afternoon. They will thank you, they will applaud you, and they will come back to your office for surgery, as will their family members. Thank you for your kind attention. Thank you.
Paul Lee, George Williams, and Carol Shields. CSEP and the New York State Ophthalmologic Society are honored to have David Park II, immediate past president and executive director of the AAO, to introduce the 2022 David Park Lecturer, David Chang. I want to mention also that David, as an example of his incredible humanitarianism and generosity, is going to give his honorarium of $1,000 for the David Park Lectureship to the ASCRS Foundation. David, thank you so much on behalf of all of us. And now I would like to introduce Dr. David Park II to introduce our David Park Lecturer for 2022. My pleasure to introduce David Park II.
An ophthalmologist, a retina surgeon, son of Connecticut, and currently the CEO of the Academy. And I really appreciate the opportunity today to say a few words before the lecture that remembers and honors my dad. You know, he was tremendously proud of being a citizen of the state of Connecticut. He was proud of his Connecticut ophthalmology colleagues, and he was proud of CSEP. My dad was very much a believer in ophthalmology organizations and in their ability to leverage the talents of individuals and be a force multiplier for good. And this was true whether it was the Department of Ophthalmology at Yale, CSEP, or the American Academy of Ophthalmology. He loved being involved in all of them, and it was really a wonderful thing to see that even though parts of his body failed him, he still had all his marbles, even into his late 90s. The opportunity today to have David Chang as the lecturer is particularly special for me, for my family, because when my dad developed cataracts, he said, I'd like to have surgery done out in California, near you, where you can take care of me. You tell me who it should be. Now we've got, as in Connecticut, lots of good cataract surgeons in the Bay Area, but David Chang was far and away, for me, the first choice. And it's not just because of his world-renowned scientific and technical expertise, the care he takes in delivering ophthalmic surgery, but it's really the relationship that he develops with his patients. When I went with my dad to David's office, it was absolutely palpable, and my dad commented on it. And during the better part of the last decade of his life, he had good vision out of that eye because of what David did and the care that David took of my dad. And I remember he came back to the house, and about a week after surgery, he was saying, "Oh my goodness, I can see the hands on that clock. I didn't even know you had a clock there." Well, we've all heard this so many times from patients, but when it happens in your own family, it really means something. And so I can't think of anything more fitting that through this lecture and having David Chang here today, it continues their connection even after my father's death. So David, thank you so much for being a part of CSEP and for delivering this lecture.
All right. Well, David, thank you so very much for that amazing introduction. And what an honor this is, as David the second said, what a privilege it was to meet David Park Sr. He was 93 at the time, sharp as a tack, and just a very charming and humble man, very interesting. And so this is especially meaningful for me. And when we talk about, contributions to our profession, we're usually talking about research, clinical, or teaching. But how many people can say we contributed a son and a grandson of this caliber to our profession? And I was struck by this quote of David Park Sr. that really kind of touches on, something that I think we can all learn from, both in respect to our own families and our relationships. And if I could just congratulate David II on ending his term as a remarkable CEO of the Academy, and ending it by getting us mostly through COVID in such with such great leadership. So as has been mentioned, when David Sr. retired, he actually did low vision and a lot of volunteer work, won the Humanitarian Service Award from the Academy in 2002. So I've chosen a topic for this talk. Basically, it's an opportunity for me to introduce the audience to what I consider the greatest team of cataract surgeons and the lessons I've learned, and I think that we can all learn from them. So I have no financial interest in any of the information here. So this was 17 years ago, and at the time I wrote that the greatest challenge we have in cataracts isn't really creating an accommodating IOL, it's the increasing backlog of cataract blindness. And the problem is intimidating for many reasons. We have limited surgeons, so how do you get them to be productive? They have to be doing high volume, rapid surgery to really gain scale. But they're dealing with cataracts that we don't here in the US, the most advanced, and complications like a dropped nucleus are blinding there when you don't have vitreoretinal surgeons around the corner. And then you have to somehow make all of this cost effective in terms of the equipment and the supplies. Dr. Venkataswamy passed away basically a year later, but he is basically at the heart of Aravind, and it's the Aravind institution that has actually solved that problem and shown us how to do it. So when he retired from his academic job, forced retirement at 58, mandatory, he founded a family clinic with the humble mission of curing needless blindness in southern India. It started as an 11-bed hospital, and he started it with loans from his family and involved his family members. And those that weren't physicians became administrators. And this is the Venkataswamy family tree. There's Dr. V. And to this day, these are all the sort of core of the Aravind institutions, which now number close to 14 different hospitals and surgery centers. And I've written on this in the past that there are lots of lessons that we can learn from low to middle income countries. And those are the 5 lessons I'll give you. So the first is that Erevin has perfected a model to eradicate cataract blindness. And their model has been replicated on different levels and a different scale throughout the world. When I started my relationship there was back when this hospital opened in 2003. I was invited to help inaugurate it with a lecture. And I met these 3 people who I've been collaborating with now for the last 19 years. And of course, I went there to teach phaco. But what I didn't expect was to be totally wowed by the way that they operate and the way that this is orchestrated and choreographed in a way that I just never thought was possible. So my friend, Dr. Venkatesh here, who is operating, I said, Venki, you know, this is something everybody in the US and in the West should be able to see. It's a long way to get here. What if you made a video and we could show it and just put on the inside what is happening in the operating room while you're showing the surgery. And this is the video that he created. So you'll see the timer here. And this is the manual small incision cataract surgery without phaco. It's a retrobulbar. You'll see it's sutureless with a temporal scleral pocket. And what you'll see in the inset is there are 2 parallel beds. And while he's operating on this exact patient, another team is going to bring in a second patient parallel to the first. And they're going to prep them and drape them and get everything ready. There'll be another scrub tech. And then in between, as soon as he's done with this case, he will go over to the other side. So this is an unedited video with a picture-in-picture. So you'll see that each of these cases is going to be done in less than 5 minutes. Now, with this kind of productivity, one surgeon, depending on how skilled they are, can do anywhere from 10 to 16 of these cases an hour. And they'll basically do 300 to 400 cases a day in this way. And these are all charitable patients. So where do they come from? Well, they do screenings at local villages, and they'll do those on Sunday. And Sunday evening, they bring everybody by bus to one of these regional hubs where they have their surgery on Monday. There you see the next patient is just laid down, is now being prepped for the surgery. So they keep their costs down by basically manufacturing everything in-house. It's called Oralab. They do the glasses, the IOLs, the sutures, the medications. Here you can see this is a funnel-shaped incision. So he's able to extract this manually, and you'll see that it's self-sealing. The PMMA IOL costs about $2, and the cost per case, excluding the labor and overhead, are basically $10 a case. So they reuse everything, the phaco tubing, the BSS, the gowns and gloves. They use what we would call short cycle sterilization, what some would have used to call flash. And in publications such as this was 600 cases, which happens to be the 2-day volume of 3 surgeons, 90% of whom were legally blind, doing about 16 to 18 an hour. And they had excellent visual outcomes with long follow-up and a 1% PC rupture rate. So here you see he's still under 3 minutes, and he's just put in a 3-piece PMMA IOL. And because this is self-sealing, this will be sutureless with no induced astigmatism because of the temporal approach. This is another paper that we did comparing phaco to this technique on white cataracts, and it was comparable. And this was all basically the genius of Dr. V. And his inspiration of all things was McDonald's. There you see Dr. Venkatesh now has finished that case. He simply swivels over the microscope. He sits down and tackles this mature white cataract with a different OR team. And what impressed Dr. V about McDonald's is that they are so efficient and you get great value for your money. And they do that because everything is standardized. You can't get a custom hamburger. It's streamlined. Everybody does it the same, whether it's a McDonald's in Connecticut or one in California. So why couldn't we do this with eye surgery? It is almost a commodity here. And they currently do about 40% of their patients pay something. And then that subsidizes the care for the 60% who basically pay little to nothing. And so this is financially self-sustaining. They don't depend on philanthropy or government funds for the actual operating room. So here he's about a minute in, and you see he did use trypan blue dye here. Now their private patients are going to pay the going rate in India, which is about $150 to $300 US. And that generates enough surplus to cover the overhead and the cost of all this charitable care, 60%. And that also eventually led to the expansion of this small clinic into the current Madurai hospital. They then, over time, opened up different regional centers and other places in southern India. And we're now 2003, this video is in the Pondicherry Center. So here you're going to see he's prolapsed this into the anterior chamber and he'll extract it. So they currently do the largest volume of cataract surgery in the world as a system of these 11 regional hospitals. And what's most important is they do an enormous amount of training. It's estimated that 1 in 6 cataract surgeons in India have been trained at Yerevan, but they will train foreign doctors, some of whom stay for anywhere from 1 to 3 months. And this is enormously important because these doctors, say from sub-Saharan Africa, from Southeast Asia, are learning this manual small incision technique, as well as phaco, and learning the Yerevan system to try to bring that back home. So here again, you're going to see he's going to place the lens, and this whole case, you can tell, is basically done in 3 minutes. And it's amazing how efficient they are and cost effective. And then you see the patient alongside is getting ready. So for those of us that do all we can to have a fast turnover, we can only dream of this kind of volume. So the latest hospital is this one in Chennai, and this is the largest of the Yerevan systems. And the woman that you saw, Dr. Haripriya, runs this. So that's lesson number 1. And lesson number 2 is that this technique is probably something all of us could practice and get better results with our most advanced cataracts. Dr. Venkatesh and I have published some of the things on this, and I had some firsthand experience with this in 2005. I did a study with Jeff Tabin and Sandik Ruit in Nepal. We did a randomized trial where at a cataract camp, the patients were randomized. Here you can see that 1 out of 4 was blind with mature cataract. They were randomized to having either phaco done by me with the Western equipment, a Western phaco machine, or this manual small incision method by the Nepalese master, Dr. Ruit. And you can see that the complication rates were about comparable. I was really, really nervous because these were such advanced cataracts, and all I could think about was having, David Chang with a 30% capsule rupture rate published and immortalized in the literature. I had one case of PC rupture. It took me 45 minutes to handle, and I barely finished the number of cases that we had to do. In short, I had more corneal edema. These were ultra-brunescent cataracts, but they did clear. We didn't lose any corneas. And if you look at uncorrected acuity, which is in developing countries, frequently, patients aren't going to wear glasses. They're not driving. It was pretty darn comparable. 20/60 is the WHO sort of definition of functional vision. So that's at 6 months, and this is at a year between the group. So uncorrected acuity was pretty comparable, and that's because this temporal shelved incision doesn't induce astigmatism. And if you look at BCVA, there was no difference at 6 months. And at a year, the phaco patients that I did were a little bit better than Dr. Ruiz in terms of, acuity BCVA. And that's because we're starting to get PCO because he's using a PMMA lens with a rounded edge. And I had my Rexus with a square edge foldable PC IOL. So, but we found enormous differences in terms of cost per case and the OR time with comparable acuity at 3 weeks. And, we said the safety was similar, but I can tell you most of us would have, a higher complication rate doing phaco than manual small incision with these cases with poor corneal visibility. Dr. Harapriya and I then did a much larger study using the Madurai flagship hospital, comparing the safety rate of phaco and manual small incision. And this was just a 12-month period in 2009, 80,000 cases. That would take 15 years at many of our institutions. This is 1 year at one hospital. We looked at reoperations and ophthalmitis, and then looked at the difference between trainees and experienced surgeons. And they have their equivalent of the IRIS registry, which they've had now for more than a decade. This is their own EHR. And so you can go in and get all sorts of data here. So you can see that out of these 80,000, the complication rate was pretty comparable between phaco and manual small incision. But if you look at the trainees, okay, so over here, this is the staff, complication rates, phaco in purple, pretty comparable. But the fellows had higher complications with phaco, the residents even higher, and these visitors, remember, from foreign countries such as Africa, had really much higher rates of complications with phaco. And so this was very obvious. So we felt that with experience, both techniques worked well, but inexperienced surgeons or those that don't do a high volume are going to get a much higher complication rate with phaco using these very large numbers. So what do? When I face a case like this, I still have a handful of cases every year where I use my manual small incision. I make a scleral pocket. Here I'm stretching the pupil after sphincterotomies with trypan blue. I do a can opener. I extend it. I express the nucleus. I do my INA. I put in a PMMA lens. And I use, because it's the US, I use a suture. I'm kind of a wimp. Whereas they would leave this unsutured. These are eyes that they're just generally not worried about astigmatism when they come in with the cataract like that, and they get a rapid recovery and the cornea looks quite a bit better. Well, PCO, we talked about that from the other study. It's an inconvenience for us and our patients, but in developing countries, it's the second leading cause of impaired vision because so many patients don't get diagnosed, or even if they do, don't have access to a YAG capsulotomy. So Dr. Nishi, first did some of the seminal work. These are rabbit eyes, and you can see that with the PMMA lens, you can see the PCO behind it. And he kind of drew the conclusion that when you have a round edge to your lens, the lens epithelial cells can get behind the optic, whereas the square edge, such as with this Ascrs soft, cause a bend and block the migration of cells from the fornix behind the posterior capsule. And he repeated these studies using a square edge PMMA lens and found this was comparable to the Ascrs soft. And his rabbit studies were well known to us. So, I kind of told the people at Irvine, what do you do to prevent PCO? Why don't we try to put a square edge on the IOL? And we had some people from industry in the US help us with that and came up with a way to do this. The modification costs about $1. So this is a study that this is showing that square edge PMMA lens. And this was Dr. Harapriya's patients. And what she did is took bilateral eyes of 50 patients, put a round edge and a square edge PMMA IOL, one in each eye. She actually did another group of 50 patients where we did an Ascrs soft in one eye and a square edge PMMA IOL in the other, and then did photographic serial photographs to look at PCO scores over time. So what you'll see here is surrounded by green is that square edge PMMA IOL. Takes an extra $1 to make this. And when you compare it to a round edge PMMA IOL or a square edge acrylic IOL, so these are two patients, just their two eyes followed over time, you can see the inhibition of PCO. Now, we followed a lot of these patients for 9 years. This is very unusual to have this kind of follow-up, and that's what I'm going to show you here. So the square edge PMMA IOL is in blue. The PCO score on the left is rising, and you can see with the round edge, there's much higher PCO at 5 years, and when you go out further to 9 years, it keeps going up, which suggests that it's just a matter of time before people with a round edge PMMA IOL are going to get PCO. So compare that to the Acrosoft. The Acrosoft was still even higher, and we think that that's because it wasn't a continuous square edge all around the edges. So this was pretty impressive to look at a 9-year rate, and so as a result, all of the lenses that are PMMA now at Aravind are square edged, and they supply an enormous amount of these low-cost PMMA IOLs to other low to middle income countries internationally, and they're all now made with a square edge. All right, lesson number 4 is that intracameral moxifloxacin prophylaxis is safe and effective. Believe it or not, it's been 15 years since the ESCRS study on cefuroxime. And as I wrote in this invited editorial, the debate still continues because we don't have a commercially approved product in most of the world. So we undertook a study to look at their preparation of moxifloxacin. This was done at the Madurai Hospital and just the manual small incision. So you can see it's almost 80,000 patients in about a 1-year period again. And so the group that got the intracameral moxi had a 5-fold reduction in endophthalmitis. So here you can see the actual case numbers, 30 cases in the first half year, and then 6 cases in the second half, showing the benefit of the intracameral moxi. Now, they actually make this at Orolab, and it's approved in India for intraocular use. It's the same concentration as our Vigamox. Comes in this vial and it costs $1. I told you they reuse everything, so they can use this on anywhere to 5 to 6 patients. So it's basically 15 cents a dose. And you can see the drop in endophthalmitis rate. And so our conclusion was, if you're going to do things that would not be allowed in Western ORs because of concern of infection, well, it makes sense with this manual small incision, particularly if you have to work in a sort of outreach facility. Sometimes it's not even a hospital, to spend $1 or less on an intracameral moxifloxacin. The results were so impressive to them with their monthly high volumes that then they immediately adopted this across the entire system. So we published data when we got to 300,000 before and after. And then the final iteration of this was when we had 1 million cases consecutive without, 1 million cases consecutive with intracameral moxi with the drop. This is a chart worth looking at because each of these bars is a 3-month period. And so the blue means without moxi, the orange means with, and I explained that there was a transition. So that during that 1-year period, there was both with and without. And what's amazing is just look at the volumes on each of these 3-month periods, 64,000 cases, 73,000 cases. So that's a 3-month period with enormous volume. And you could take any of the orange and any of the blue bars and compare them, and it's very statistically significant. So here we see those 2 million cases, the breakdown. The infection rate went from 7 per 10,000 down to 2 per 10,000. Now, that was true whether there's the 7 and there's the 2. That was true whether you looked at the manual small incision. There was a 3-fold reduction. With phaco, it was a 6-fold. And where is this 2 per 10,000 now comparing? Well, Our data from the IRIS registry is 4 per 10,000. So they're getting rates that are as good as ours. The other thing we looked at was posterior capsule rupture, because we had enough, almost 28,000 cases now. And let's just look at that for a moment. 28,000 consecutive cases of PC rupture. And these are the eyes without intracranial moxie. So their overall rate is about 1.5%, pretty comparable to other large published rates around the world. And you can see that the endophthalmitis rate is up 7-fold. You get a 7-fold increase when the capsule ruptures because now you have no barrier. What happens with moxie? Well, you still get an increase in PCR with, in endophthalmitis with PCR, but it's much lower than if you didn't use the moxifloxacin by about a half. So we also, this gave us a chance to look at uncomplicated cases, because if the PCR rate increases endophthalmitis significantly, what about uncomplicated cases? You can still see that with moxie, it really lowers endophthalmitis in uncomplicated cases as well. Phaco, for instance, you go from 6 per 10,000 down to 1 per 10,000 in these 300,000 eyes in each group. So this, to me, is sort of the best evidence right here, argument for intracranial moxie, 300,000 phacos with and 300 without, and you drop the rate by 6-fold, and this is excluding a PCR. All right, so how is this influencing us? I led efforts in 2007 and 2014 to do the ASCRS clinical survey, and we just completed the one for 2021. It's actually published in the January issue this month of JCRS. And we had, again, 1,200 respondents, and let me just show you the results. Now, what's nice about these surveys, I use the exact same question in all 3 surveys, so the results should be comparable. And you can see the rate of use of intracameral antibiotic has steadily risen to now 2 out of 3 of us. And most of us are directly injecting this, whereas back in 2007, it was half were putting it in the bottle. But the agent of choice now is by far and away moxifloxacin, 3 out of 4. Vancomycin has dropped to 6%. And if you go back just to the last survey, it was the #1 most common antibiotic chosen, especially if you look at just the United States. So it was by far and away the leader in the US. And of course, the reason that's fallen off is HORV. We also did this study at Erevin where we compared 0.1 ml of a lower or a higher concentration. And we found that there was no difference in endothelial cell loss, which says that then you should use the higher concentration, which is what they are doing. All right. So the final lesson is a very important one. And that is that many of the regulations that cause us to throw things out in the operating room are of unproven benefit, but are increasing our costs and our level of waste. So this is an article we wrote for the Royal College of Surgeons had a special issue of their bulletin devoted to planetary health. And we wrote this one again about learning from low to middle income countries on how to optimize resources, because they cannot afford to be wasteful since they have limited resources to begin with. And the point was that we could learn from them. A bit of history. In 2009, the Joint Commission decided that nobody should use flash sterilization. And they basically said, all the ophthalmology ASCs and centers, if you're not doing a full terminal wrap cycle, like you do at the end of the day on Friday, basically a 1-hour cooking, you can't operate. And this came out of the blue. And I was on a task force from the Academy and ASCRS. And we just made the case that, well, this is what we've been doing. And they said, well, show us where in the literature you have any documentation of what your endophthalmitis rate is. And we didn't have one. So I wrote to Dr. Venkatesh and Dr. Ravindran, And we quickly pulled out the case numbers at this Pondicherry Aravind, and we're able to show that, they're reusing all these things, but specifically using this short cycle sterilization without wrapping the instruments, a very quick cycle, and that the rate was low. And this paper was actually what convinced the Joint Commission to allow us to continue to do this short cycle sterilization. This continued to come up. It actually came up again in 2014 when CMS came out and said you can't do this short cycle. And similarly, we had to do studies to kind of defend it. So 2 times we successfully defended our use of rapid short cycle sterilization. And part of this, this was part of a large effort on many different fronts to sort of say that eye instruments are different from general surgical and orthopedic instruments. And so we led this effort, again, a joint effort from the Academy and Ascrs and US on specialty specific guidelines for the cleaning and sterilization of intraocular instruments. Now, some really important data has come out of Aravind. This is Cassie Teal. You see Dr. Venkatesh over here. And they've done this life cycle analysis to look at the carbon footprint of cataract surgery. And what they found is that it's much lower there than it is in the West. I was surprised to learn that 10% of carbon emissions in the US from the healthcare system. It's been a huge increase. We're double that of Canada and the UK, where it's about 5%. Most of this is from the OR and labor and delivery. And if you just extrapolate to the number of cataract surgeries that we're going to be doing in the future, you can quickly see that this level of waste is unsustainable, both from the carbon footprint and the financial burden. We already know how large a percentage of Medicare's budget just goes to cataract surgery alone. So this is an important area. And this is the work done at that Pondicherry Aravind. Basically, this is one cataract, the carbon footprint in the UK, a phaco. It's equivalent to driving a car 300 miles. Whereas one phaco now, not the manual small incision, this is phaco at Aravind, it's equivalent to driving a car 15 miles. It's a 20-fold change. And where is the difference coming from? A lot of it is equipment and pharmaceuticals, basically throwing everything out after you use it once. This is my OR, the waste after a typical day. This is 28 cases. This is 93 cases from one day at Aravind in comparison. You might say, well, when you reuse stuff, what about TAS? So we actually did a study of TAS at Aravind, and this included 2 outbreaks, and we found that the rate was still low, even though they're reusing everything, and that there was no situation where people lost vision from that. So when I was chair of the AAO Cataract PPP, and also in these guidelines that I just mentioned, tried to editorialize about the fact that we have to not just keep adding more and more regulations, kind of practicing defensive medicine. We really need to, ask for evidence, not just eminence in terms of new regulations. So this led us to this survey. It was done jointly, again, from this task force, the Academy, ASCRS, US, and the Canadian Ophthalmology Society. Cassie Teal and I wrote the questions and conducted it. And we had more than 1,300 people responding, more than 1,000 surgeons. 9 out of 10 are concerned about global warming, but pretty much unanimously, or a strong majority feeling that we are wasting a lot and we should look for ways to reduce our OR trash. 5% said no changes are needed. So just a couple of highlights. What are the main drivers of the waste? Single-use packaging. We've got our facilities and regulatory agencies limiting our discretion on what we can reuse. And then manufacturers mandating single use to limit liability or to drive us to more profitable products. Now, these are just different categories where respondents were asked, would you reuse or be willing to? So topical, intraocular, and supply items. So topical drugs, it turns out that most people are either already reusing them or would consider it using them from a multi-bottle. Well, that's a no-brainer. And here's intraocular, almost as high, willing to reuse on multiple patients or already using. And then more intraoculars. Turns out with compounded, again, most people aren't reusing them, but are willing to consider that. Again, following what is kind of being done at Erevin. And this is just supply items like the phaco and INA tips, the tubing, and even needles. Supply items, cannulas, blades, sutures. So the consensus here was that, yes, our colleagues are concerned about global warming. Trash is excessive. We all want more options, perhaps reusable or multi-use. If given a choice between a reusable and a disposable instrument that were of equal cost, 10 times as many people would prefer the reusable one. And then discretion to reuse and manufacture consideration of carbon footprint. So this was the survey on the left that was published, and then I was invited to write this editorial when after that survey came out in Ophthalmology on Needless Waste. And I basically put these two studies alongside each other. First, the Cassatt study that said, you know, our carbon footprint in terms of largely due to waste of drugs and supplies is 20 times higher for one phaco. And yet our infection rate is no lower. In fact, it's a little higher if you compare what we get from the IRIS registry. So when you put that together, what does it say? Well, we are wasting a lot that has really, and there's really no proven benefit for throwing things out every time we use them. This is a study that just came out online this week from the British Journal. And this is a study that we conducted during COVID when it first happened in 2020. You'll recall that everything shut down. And so when they reopened at Erevin, they kind of followed the Indian Society national guidelines. And so prior, you know, their normal thing was just let people wear their own clothes in the OR. Here, they put everybody into scrub gowns. I showed you that they might have multiple patients in the OR at a time. Well, they only had one at a time, right? What if the patient was COVID positive? We were all being so careful. And they never changed gloves in between cases before, but this time everybody would change gloves in between every case. And you can see that during these time periods, we still had a large number of people at this, one hospital. And this is the infection rate. It was the same. So the idea was basically, if we adopt all these standards and protocols that are used in the West, would that actually reduce the infection rate? And we could not find a change here. So, at least adding a little more data to this argument. So to summarize, I'm just so fortunate, I think, to have had this relationship with Erevin. I just want to share some of these lessons that manual small incision is much more affordable and scalable. It's very comparable to phaco for surgeons that are not highly experienced at phaco. And because it's scalable and affordable, it's a great solution for global cataract blindness. But I think we would all, if we knew this, would have better results if we selectively use this manual small incision on some of our most difficult cases instead of trying to do phaco on everyone. We talked about PCO rate and how the square edge, it's not the material, it's a square edge that reduces PCO. And I think this has given us the strongest data on moxifloxacin. And even if you aren't convinced you need it routinely, if you do break the capsule, please consider that. And then finally, this very important lesson that, we really should reevaluate a lot of what we're doing in terms of what evidence is there that it makes any difference. So I just want to end by circling back to Dr. Venkataswamy. This is one man's vision to found the Aravind eye care system. And it's really an amazing group of people. And this is, I owe a lot to them, and I've just thoroughly enjoyed the 19 years now that we've collaborated on many things. But as Dr. Venkataswamy would always tell people, don't rest. There's still plenty to be done as long as there's a lot of global blindness. So I again want to thank the Society. This is such a wonderful honor, and thank you again for the time today.
David, thank you so much. That was extraordinary. Your wisdom, your experience, your talent, your surgical skills, your ability to condense and collate mountains of information and give us compelling evidence for what you have suggested, despite what we think we know in our experiences, is really extraordinary. A couple of questions. I was amazed at the lack of corneal edema in the cases that you did in Nepal, given that they were hard cataracts, brunescent cataracts, white cataracts, and we both know no matter who you are, no matter how much viscoelastics are being used, that's just an extraordinary low number. So any thoughts or ideas about why? It's a great result, but why?
Yeah, well, in my cases, I had more corneal edema. We did pachymetry, not cell counts, but I'm happy to say, I was using a good viscoelastic. We brought all this stuff over, and I was, I had a dispersive viscoelastic. The hardest thing in doing the cases for me over there was, not having an eye drape, and having just a terrible tear film, and everybody has trachoma, and you just get terrible red reflex. But the real point, to your point, Vinny, is with the manual extra cap. It's just with that larger incision and doing a lens loop extraction, it's incredibly gentle on the cornea. Now, you might look at that and say, well, everybody, was about the same at 3 weeks. It didn't make any difference in the long term. But when you're doing these outreach, a lot of the patients who are a little worried about having surgery, they want to talk to the people that had surgery yesterday. So having a clear cornea on day one is actually really important, because of course, this patient population doesn't have the concept of the eye has to heal and then you'll see better. Right,
I got you. And they come in like perception or hand motion to start with, so that their expectations are different from our 20/60 patients or 20/80 patients. Were you looking at Fuchs dystrophy, or were you looking preoperatively at endothelia? You're just going right ahead.
Yeah, no, they did have pachymetry pre and post op. So that was the Nepalese,
Right.
Yeah.
Extraordinary data there. One question that came up from our audience is the position of the intraocular lenses in MSICS, sulcus or capsular bag, and how do you know?
Yeah, so people do it differently. In Nepal, they're making a triangular capsulotomy, and so it kind of creates a little bit of a bag-like configuration. But at Aravind, they're doing a large CCC. So that, in fact, is, of course, the best combination with a square edge PMMA IOL. That combination is going to reduce PCO the best. But the nice thing is these are larger 3-piece IOLs. So if it ends up in the sulcus or one haptic pops out, the centration will still be fine.
Right. David, thank you again so much. On behalf of CSEP and on behalf of the New York State Society of Ophthalmology, we cannot thank you enough for your extraordinary lecture. And congratulations again on being the 2022 recipient of the David Park Lectureship. Thanks so much, David. See you at ACRS, hopefully live. Thanks again. Okay, moving on to our next speaker, Dr. Russell Van Gelder. Dr. Van Gelder is the Boyd Busey Professor and Chairman of the Department of Ophthalmology at the University of Washington in Seattle, and founding director of the UW Medicine Eye Institute and Vision Center. Russ is a native New Yorker, but he went cross-country to get his undergrad, medical, and PhD degrees from Stanford, and uveitis and ophthalmology residency and uveitis and medical retina fellowships at WashU in St. Louis, where he was on on faculty there as the Bernard Becker Professor. Many of you heard Dr. Van Gelder's terrific talk at the Academy. He gave the Jackson Lecture at the Academy in November. I was here home in Connecticut. I was going to go to New Orleans, but because of COVID, I stayed, gave my own talk by Zoom, but I was absolutely transfixed by Russell's talk on molecular diagnostics for infectious diseases, which he's going to be giving to us. I just want to mention real briefly that he was the recipient of the Translational Science Award of the Burroughs Wellcome Foundation, the Heed Gutman Award of the Heed Foundation, the Bressler Prize winner of the Lighthouse Guild. Not only that, but he serves as the past editor of IOVS, the editorial board of ophthalmology, and he's been, of course, a past president of the American Academy of Ophthalmology. So it's my great pleasure and great privilege to introduce Dr. Russell Van Gelder, who will give his talk, Molecular Diagnostics for Infectious Eye Diseases, New Techniques and New Insights. Russ, thank you.
Great. Thank you so much, Vince. Really appreciate this opportunity. I wish I could be there in person, but we're not quite there yet. And thank you for the kind words and the kind introduction. I'm going to go full screen here. Hopefully everyone can see that okay. For those of you who were at the Jackson Lecture, thank you for coming or watching remotely. This will be a little bit of a redo. I put some different information in this, but only so much you can say about molecular diagnostics. So there will be a little bit of this that's redundant from the Jackson Lecture. To start, I have no conflicts of interest. I do receive grant support from NEI and Research to Prevent Blindness for some of the work in my lab. So, you know, it's fun sometimes to think about what the world was like 100 years ago when Betty White was born. If you transported yourself back to 1922, what would look familiar in an ophthalmologist's office or daily practice? And a little bit would look familiar. So the slit lamp dates from about 1916 or so in Van Gullestrand. The phoropter has been around since at least 1920. Obviously the Jackson cross, the name eponymous tool of Dr. Jackson. I think the direct ophthalmoscope goes back to von Helmholtz in the 1860s or 70s. And the streak retinoscope is also a 19th century technology. So all of that stuff that would kind of be on the patient stand would look vaguely familiar. But from someone's standpoint in 1922 to come into 2022 office, a lot of what we do would be completely foreign and would really border on science fiction fantasy as opposed to reality. You know, some of it is sort of in that in-between land, like a indirect ophthalmoscope, which dates from the 1950s. Obviously, intraocular lenses came out not too long after the 1920s with Sir Harold Ridley in the 1940s. But when we start to get into laser photocoagulation, femtosecond lasers, and then as we get into OCT angiography, some of these technologies really are amazingly advanced and were truly inconceivable in 1922. But if a corneal ulcer walked into an office in 1922 or walked into my office today, really the management would not be terribly different, at least in terms of the diagnostics. We would take either a scalpel blade or a sterile swab. We'd get a little piece of the edge of this ulcer. We would go get our blood agar and chocolate agar plates, and we'd get something labeled with some medieval label like brain heart infusion or Sabarode's medium. And we would swish this stuff around, put it in an incubator and hope something grew. And then we might take a little bit of this and smear it on a microscope slide and stain it with gram stain, which dates from the 1890s. And that hasn't changed a whole lot in daily practice. This is what we teach our residents to do. And it's what basically every living ophthalmologist today was taught to do with a corneal ulcer. Now, why has this not advanced the way everything else in ophthalmology seems to? And it's not because this is a perfect technique. We know that the culture positivity rate of corneal ulcers is approximately 55%. So 45% of the time, we don't get a bug despite doing the standard that we've been doing for over 100 years. And the same is true of almost all of our infectious diseases. Endophthalmitis, you're pretty sure the eye is infected, and yet you stick a needle in that vitreous, and 30 to 50% of the time, nothing grows. So enter molecular diagnostics and sort of 21st century diagnostics. What is molecular diagnostics? Well, the fundamental principle is that we're going to be trying to detect pathogen DNA or RNA as a proxy for the presence of that organism in a tissue, meaning if I can detect the DNA of Staph aureus in a tissue, I assume that there's Staph aureus there. Or if I get herpes simplex, I assume there's herpes simplex. And the key to this technique and the reason that it's become useful in this century is really the polymerase chain reaction, which we'll talk about in a second. So PCR, as it's known, and I think prior to the last 2 years, this was something I had to explain to people in more detail, but PCR has become kind of a household acronym, was really invented by Nobel laureate Gobind Khorana. And if you go back in the literature to a 1971 paper that he published with a couple of his students, they clearly lay out the idea of using DNA polymerases with the building blocks of DNA, that is deoxynucleotide triphosphates, to synthesize DNA in vitro, potentially in a way that you could grow large amounts of it or synthesize large amounts of a template rapidly in a test tube. The basic idea is that you start with a target, and this is going to be some DNA that you're trying to detect in your biopsy sample. And you need 2 primers or complementary oligonucleotides that bind to regions that are unique to that gene. So that could be any gene in the genome of your organism, but you need one in red, which we'll call here the upstream, and one in blue, which we'll call the downstream. And so you basically put the oligonucleotides together with your denatured single-stranded DNA. You cool the tube down so that this can anneal. You then add DNA polymerase and deoxynucleotide triphosphates and the correct salts and buffers. And if this oligo has hybridized, you get synthesis of a new strand of DNA. This is what happens in our cells all the time. It's just being performed in a cell-free extract. Now, the magic of this is when you denature. So if you heat this up and the 2 strands come apart, this black strand again becomes the template for another upstream primer to anneal and extend. But the magic of the technique is that the red strand here, the newly synthesized strand, becomes the template for a downstream primer, this blue primer, to anneal and be extended. And so at the end of 2 rounds of PCR, we now have 4 copies of the DNA that we started with, 2 that are the same strand and 2 that are the antisense strand. This technique really became practical in the late 1980s when Kary Mullis, also a Nobel laureate recently deceased and a very colorful character, thought of using a thermostable DNA polymerase to do this so that you wouldn't have to continually add enzyme to the reaction. And he purified these thermostable polymerases from the bacteria that live in the vents of the thermal vents at Yellowstone, which was a very clever way to do this. So the magic of the technique is that each round doubles the amount of DNA. So you accumulate 2 to the X, where X is the number of rounds. And after 10 rounds of amplification, you get 1,000 copies of whatever you started with. After 20 rounds, you get 1,000,000 folds. And after 30 rounds, you get 1 billion copies, exact copies of whatever you started with. So this is an incredible manufacturing operation on a nanoscale. And when you have 1 billion copies of DNA, that becomes an analytic quantity. You can actually see it physically on a gel or stain it. And this is the magic of the technique and why it's so sensitive. Now, as I mentioned, PCR prior to this year really was not something that your average person would talk about. When I flew to the academy in the lounge waiting for the airplane to take off, I heard at least 3 different groups using PCR in their discussion. Oh, did you get a PCR test before you went? Oh, they made me take a PCR test. So now that we have SARS-CoV-2, I'm sure that almost everyone, if not everyone in this audience, has had their tissue subjected to a PCR test. This was as of November. There were about 558 million tests in the US, and that number is probably close to 1 million at this point with the Omicron surge. So the technique as I've described it is useful, but not terribly useful. And a few of the things that my lab did in the early days of PCR were to make this multiplex so that you could test for multiple pathogens at the same time. Each pathogen requires its own primer set, but there's some molecular biology tricks that you can use to combine multiple primer sets in one reaction, and therefore test for example, herpes simplex, varicella zoster, and cytomegalovirus all in the same tube. And then we also brought a technique called real-time PCR to the field, and this is widely used and in fact is standard now. where by using standards for the PCR reaction and measuring the accumulation or the amount of product that's made over time, you can estimate how much material there is in the starting sample. It's akin to a titer. And when you get PCR now from most commercial labs, they automatically do it as a quantitative qPCR or real-time PCR. One of the things PCR turned out to be very useful for in the early days was diagnosing rare conditions that are hard to diagnose otherwise. This was a case that Mike Connors and I saw together at WashU of a microsporidial keratitis. Very difficult to diagnose this either by microscopy or culture. But when we made PCR primers specific for the microsporidial organisms, we were able to readily amplify this from these corneas and confirm the diagnosis. This case was actually, I'll go to this one first. This was an unfortunate case that Paul Langer at New Jersey Med School shared with me of an enucleated eye that clearly had some awful endophthalmitis requiring the enucleation. And despite all of this pus in the middle of this eye on histology, they never got a diagnosis as to what the bug was, and therefore couldn't judge whether the patient was at further risk from other infections. So they asked me to try to identify this by PCR, and using a 16S PCR technique we'll talk about in a minute, we were able to identify Actinomyces israeli as the causative organism here. This one was the one that really piqued my interest. This was a patient who had a multifocal choroiditis. This was a bone marrow transplant patient who had a cellulitis in the hospital. And this turned out to be, based on a blood smear, looked like an algae, which is so unusual. The patient had a systemic algemia with an organism called Prototheca wickerhamii. And he passed away from this, and he was a physician. His wife granted us the permission to use the eyes at autopsy. Mort Smith took tissue punches of these little lesions, and we PCR'd for this algae, Prototheca wickerhamii, and sure enough, there it was. So this is the only case that I'm aware of algal multifocal choroiditis, not a bug you want to get, not a lot of good treatments for systemic algemia. PCR has been used to link diseases, and a couple of important diseases to know about that are linked to pathogens now through PCR. One is this disease, Fuchs heterochromic iridocyclitis. You're probably all familiar with this. It's a unilateral, typically unilateral anterior uveitis, very asymptomatic, elevated eye pressure, iris atrophy, and usually a cataract. And this turns out to be due, at least in the US and Europe, usually to a rubella infection, which is pretty interesting. The other disease that has yielded to PCR is Posner-Schlossman syndrome, or glaucomatous-cyclitic crisis, which Sufei Chi and colleagues showed is actually a cytomegalovirus infection in an immunocompetent host, and can be treated with antivirals quite successfully. Now, this case was really the case that got me very interested in what I'll talk about in the last half of the talk, and that's novel pathogens. So this was a gentleman in St. Louis who came in after a gardening accident. He was out mowing his lawn and felt something go in his eye, didn't know what it was. And I saw him a couple of months after he'd seen several other ophthalmologists with this very ugly looking process going on. This is intracorneal, and in the anterior chamber, his cornea is thinned out significantly on the nasal side here. And Tony Lubnowski, my cornea colleague at WashU, thought that we probably should do a PK sooner rather than later. He had been cultured. He had had 2 corneal biopsies that hadn't yielded anything. It certainly looked infectious, but no one knew what the infection was. So he underwent a PKP, and I asked Tony to give me some of that AC material and the corneal button. And sure enough, when we PCR'd it with a special primer called 28S, we saw the presence of fungal DNA in both the cornea sample and the anterior chamber sample. This is a positive and a negative control. So it took in those days about a week to get this result and to start sequencing it. And so I asked Tony how the patient was doing post-op, and like a typical cornea guy, no offense to the cornea guys in the audience and gals, but Tony said, "Oh, he's doing great. Cornea looks super, but there's a little uveitis. I'm returning him to your practice." So we had a small little hypopyon to deal with there. And at that point, I talked to the patient and basically said, "I think this is fungal, but we sequenced this piece of DNA and it's not in the database. This is a new fungus that has not been reported before. But how about if we treat you as if it's fungal?" And he said, "Of course, do what you need to do." So we put him on natamycin and itraconazole, and 2 weeks later, he looked like this. And when I left St. Louis 2 years later, he was 20/25. So how many cases do we see of these fascinoma inflammatory cases that would turn out to be algal multifocal choroiditis or novel fungus keratitis? We just don't know. So we did a study. I'm glad Dr. Chang introduced Aravind. This was a study we did at Aravind with our friends from UCSF, looking at corneal ulcers. Corneal ulcers are epidemic and endemic to India. And so I had a student, Elma Kim, who went over to collect corneal ulcer samples from Aravind. It took her all of 2 weeks to collect 108 corneal ulcers from that hospital. And we PCR'd all of them and compared those results to the culture results. These are the PCR for both bacterial 16S DNA and fungal 18S or 28S DNA. And you can see that all of the samples pretty much came up positive for one or the other, but generally not both, except for the sample 107. When we looked at the results, nearly all of the culture positive swabs were PCR positive for the same organism. So we would recover whatever it was that was in that in the growing sample correctly. The interesting ones were the 52 swabs that were culture negative. Again, about 50% of the samples that we were dealing with. And we did get a PCR result on 46 of those. They broke into 17 that were bacterial and 29 were fungal. And that's the proportion of fungal to bacterial in India for corneal ulcers, generally about 2 to 1. So on the bacterial side, it was mostly missed bugs. So Corynebacteria, strep pneumo, Pseudomonas, staph epi, H. flu, these are all things that we expect to cause corneal ulcers, but there were 2 novel bacteria in that group. The fungal group were more interesting. So of the 29 fungal positives, 17 were either Fusarium or Aspergillus, but the other 12 were either very unusual fungi, Sordaria, Phythium, Botrytis diplodia, or an uncultured fungus. So if you add up all the red and orange here of unknown or weird bugs, it ended up being 14 of the 46 were unusual bugs. And it suggests the PCR could be detecting a wider range of organisms than we're really accustomed to dealing with from culture. Now, PCR has been an extremely successful technique, but really deep DNA sequencing is poised to replace this. And the idea of deep DNA sequencing is that the technology has gotten cheap enough now to just sequence all of the DNA in a sample and not selectively try to amplify any of it. This is an Illumina MiSeq, which we have in my lab. This machine is capable of sequencing about 2 billion with a B base pairs of DNA a day. And the basic idea is to brute force sequence your way through a biopsy and then use metagenomic techniques to try to identify the non-human DNA or find the needle in the haystack. And we've developed a couple of techniques over the years, including BRISC, biome representational in silico karyotyping, and SMART to do that. So let's look at 2 examples of where deep sequencing has given us some insights. The first is endophthalmitis. As I mentioned before, in the endophthalmitis vitrectomy study, about 30% of cases were culture negative, but more recent studies suggest that 50% don't yield an organism on culture. So we have very poor yield. Yet you look at this eye 48 hours after surgery or an intravitreal injection, and you're about 99% sure that there's something growing in there, given the clinical appearance. So we did an initial study, which Aaron Lee, my colleague, first authored with our friends at Wills Eye Institute, particularly Sunir Garg. And we took 21 successive endophthalmitis samples and subjected them to culture, 16S PCR, and our technique called BRISC, which is our deep sequencing technique that we used in this study. And what we discovered was that about 7 of these samples were culture negative, and all 7 of those samples, which are highlighted here in the yellow, were also PCR negative for bacteria. So unlike the case with the corneal ulcers, where the culture negative samples were PCR positive, for endophthalmitis, it appears that the culture negative samples really don't have a lot of bacterial DNA in them, that they're really truly either negative or paucibacterial. But interestingly, the deep sequencing revealed this organism, TTV or torctenovirus, in about a third of the samples and in most of the samples that were culture negative. And that was pretty interesting. So what is torctenovirus? It's a small single-stranded DNA virus. It's an anellovirus technically. It's nearly ubiquitous. Almost everyone has antibodies to this virus. It is not linked to any known disease. It's almost like a commensal virus that we all carry. And we've found it quite frequently on the ocular surface. And this is a PCR of some work that Thuy Duan, who's not UCSF, did when she was in my lab, looking at PCR of anterior corneal and conjunctival scrapings and showing about half of these samples were positive by PCR for torctenovirus. This had actually first been discovered in a disease that's endemic to Nepal, as Dr. Cheng was discussing Nepal, called SHAPU, which is called seasonal hyperacute panuveitis syndrome. And this entity really looks like an endophthalmitis. It occurs in children in concert with the hatching of a particular moth. And it's thought that the little hairs on the moth's abdomen get into the eyes and actually burrow in the way sometimes tarantula hairs do, and they might take bacteria with them, or they might be immunogenic themselves. And what Todd Margolis and George Verjean showed a few years ago, and really the first demonstration of torctenovirus in the eye, was that a majority of SHAPU patients did indeed have torcteno. They also showed about half their endophthalmitis samples had torcteno, similar to what we found in our study. So does this have any prognostic implication? In our first endophthalmitis study, we unfortunately did not take the samples, we did not take the outcomes of the patients, we merely had their samples. We didn't have a protocol that let us follow the patients. So we redid the study with 50 samples where we had long-term follow-up and could assess whether positive results on deep sequencing were correlated with better or worse outcome. When we looked at our samples, we ended up getting good whole genome sequencing, and this was done with the SMART technique in 42 of those samples. And generally, where the samples were culture positive, they were whole genome sequencing positive. And again, where they were negative, they were generally both culture and whole genome sequencing negative. Now, of note, we did have 8 samples that were culture negative that were positive on whole genome sequencing. 7 of those were staph epi. And we suspected it was just a case of not being able to grow the staph epi, but that was a minority of the total cases. We only had 2 cases that were culture positive that we did not detect the bacteria by deep sequencing. So on the TTV question, what does TTV mean for outcome? We used as an outcome measure the need for a secondary procedure, typically vitrectomy, as a measure of a poor outcome. Visual acuity outcomes here tend to be a little bit more challenging because of comorbid disease. So the need for a secondary procedure we thought was a good outcome. And what we found was that the TTV positivity was highly associated with a poor outcome, meaning that about 80% of the TTV positive cases required a second procedure compared with only about 10% of the TTV negative cases. And if we combine culture positivity and TTV positivity, every patient who was culture positive, TTV positive required a secondary procedure. No patient who was TTV negative, culture negative required a secondary procedure. So we do think this torcteno is a bad prognostic indicator. We don't know at this point whether it's actually causative of the endophthalmitis or an adjunct or a marker of severe inflammation, but we do think that this is an important thing to know. And just editorializing a little bit, EVS has served us very well for now coming up on 30 years. But the idea that you can triage who goes to the operating room that day by saying, can you see my hand, may not be the most sophisticated way to do prognostication. And I suspect that a deep sequencing or immediate PCR-based result asking what kind of bug do you have and how much of it is in your eye is probably in the long run a better way to figure out who needs a vitrectomy and who can get away with a tap and inject. But that's speculation. Let me close the talk with our most common and often most annoying infectious eye disease, which is EKC, which of course we are all at risk for as ophthalmologists. This has been known for almost 70 years to be caused by adenoviruses. And if you read the BCSE, it will tell you that it's adenovirus species D, and it's specifically D8 and 17, and now it's renumbered 64, 37, 64. I take that back. 37 is still 37. 19 got relabeled as 64. It's hard to keep track of this. We dovetailed with or really piggybacked onto the auriclosine trial of Novabay for its antiviral, anti-infective agent. That trial enrolled 500 patients with EKC. The drug did not meet endpoint and the drug development was abandoned, but we got the 500 samples, or actually closer to 2,500 samples from 500 patients of conjunctival swabs that we could then analyze. And what we found was interesting when we did our molecular, just PCR level diagnosis. In the United States, 45% of the swabs did not show adenovirus. Whereas in other parts of the world, like Sri Lanka, 95% of the swabs were positive for adeno. In the US, it was only 55%, which suggests that some of what we're looking at as EKC in this country is not adenoviral. And this was negative by deep sequencing and by PCR. And interestingly, although type D was predominant in Sri Lanka and the majority in India and Brazil, it was a minority in the US. In fact, the most prevalent single subtype was E4. Which is interesting. We just published a paper showing that E4 is a little bit milder than D, but not by much. So my student Kenji Nakamichi went ahead and took about 71 of these swabs and deep sequenced them and reconstructed the entire viral genome. And again, I would have had to, a couple of years ago, explain this in detail to people, but now if I say this is Delta and this is Omicron, you know what I'm talking about. These are strain types that you can only detect by molecular diagnosis, and where Omicron has 30 mutations compared to Delta, we found approximately 60 mutations that allowed us to differentiate 3 different clades or substrains of D8 virus, which you can see here, sort of 1, 2, and 3. And when we clustered them, they clustered quite clearly. They did have geographic implications, meaning that, for example, cluster 2 was found mostly in Sri Lanka and cluster 3 mostly in India. Cluster 1 we found in Brazil and India. But when we looked at samples that were in the database from around the world, it turned out that all of these strains are in circulation all over the world. So these are old substrains that have been around for many years. When we looked at outcomes, we were really interested to find that the risk of subepithelial infiltrates did vary significantly with the clade. So these clade 1, Brazil, India, clade 2, all showed pretty high incidence of subepithelial infiltrates on the order of 3/4 of the patients, whereas a little less than half the patients in clade 3 had subepithelial infiltrates. What Kenji then did was he took the whole genome sequence of this virus and fed it into a machine learning system to see if you could just look at the sequence of the virus and predict which ones were going to cause SEIs. And without going too deeply into the math of this or the design of the machine learning, it turns out that a trained network was able to 100% predict both the country of origin of 16 samples that we had not previously sequenced. So these were brand new samples for us, and correctly predicted 16 of 16 for whether they developed subepithelial infiltrates. So what that suggests is that the steep sequencing gives us information about the pathogen that we could not possibly get in any other way, including really improved prognostic information for guiding patient therapy. So finally, where's the future? I think this device is the future. This is an Oxford nanopore MinION. This is, believe it or not, a deep DNA sequencing device that can churn out that same 2 billion base pairs a day as that MiSeq. The device costs about $800, and that little flow cell in my hand here costs about $80, and we can get 4 samples on a single flow cell. So this is about $20 a sample to run a total genome sequence on each sample. We're currently working in perfecting software that allows us to plug this thing into a laptop and have the laptop read the sequence in real time and figure out what pathogen is in there. And just last week, between Academy and now, we successfully diagnosed an adenoviral conjunctivitis in 10 minutes after putting the biopsy sample on the sequencer. So I think this will be, or something like it will be, the future of diagnostics, meaning you'll have an in-office test that allow you to diagnose any infectious organism by deep DNA sequencing in real time. So that was a fairly whirlwind tour through some molecular diagnostic advances in the field. I hope that's at least entertaining, if not educational. Lots of folks to thank. I want to particularly highlight Mark Daly, an ophthalmologist who's been very generous in supporting our work, the Burroughs Wellcome Foundation and Research to Prevent Blindness, and my collaborators both at University of Washington, WashU, and also Sunir Garg at Wills, and Jim Chotish at Harvard. So thank you all for your attention.
Thanks so much, Russ. That was absolutely terrific. You condensed your Jackson lecture into a half an hour. You did a phenomenal job. Thank you very much. Russ, could you leave your email address in the chat box in case folks have questions to ask you, because we're going to keep moving on.
I
with
will.
our talk.
Let me, I will put it up there right now.
Awesome. Thanks so much, Russ. Thank you for your wisdom and your expertise. Before I introduce Martha Howard of the CSEP Executive Committee and Education Committee, who will introduce Dr. Burton Kushner, I want to once again thank all of you for attending. I want to thank Deb Osborne for her unbelievable work. I want to also thank Ed Lim for his preparations as being moderator tomorrow and Saturday for the sessions, tomorrow for the technicians, Saturday for physicians. I want to thank Robin Pellegrino and Peter Menger of the New York State Ophthalmologic Society, as well as our own hardworking Jim Martone, who's done an incredible job as president of CSEP over the last 2 years. So without further ado, I'm going to introduce Martha Howard, who will introduce our last speaker, Dr. Burton Kushner. And don't go away after Dr. Kushner's speech, because we have more door prizes to give you. Martha.
Great. Thank you very much for that, giving me the chance to introduce Dr. Kushner, who I am delighted to welcome to give a talk this evening. He is a professor emeritus in the Department of Ophthalmology and Visual Sciences at the University of Wisconsin-Madison. He graduated from Northwestern University School of Medicine, did his residency in ophthalmology at the University of Wisconsin-Madison, followed by a fellowship in pediatric ophthalmology at Bascom Palmer. Then he returned to Madison, where he became the John and Helen Doolittle Professor of Ophthalmology and was director of the Pediatric Eye and Adult Strabismus Clinic. He has been editor-in-chief of the Journal of Pediatric Ophthalmology, the founding editor of the Journal of APOS, and co-editor-in-chief of the Journal of Binocular Vision and Ocular Motility. He has published over 200 peer-reviewed manuscripts, authored over 40 textbook chapters, has given over 25 named lectures, and has received the Heat Award, the Bressler Prize, and the Senior Honor Award from the American Academy of Ophthalmology and APOS, and has been listed in every annual edition of Best Physicians in America since its first publication in 1993. He's always been tremendously generous in reviewing complicated strabismus patients on the fly at meetings. Please join me in welcoming him to give his talk, What I've Learned in 45 Years of Studying Intermittent Exotropia.
Well, thank you so much. It's wonderful being here. I don't know if I'm having a technical issue. My camera is turned on. Can you see me? No.
No, we can't.
This is perplexing. This happened to me once years ago. My camera is turned on. Well, let's see if my PowerPoint shows. I don't think you need to see my face, although that's probably the way it normally should be done. Can you see my slides?
Yes, we can.
Okay,
Just wanna...
maybe I think I should just proceed like this, and maybe the camera will come on. I can't say exactly why it's doing that.
You might want to put it into the mode for presentation. That's it.
That way.
Perfect.
So what I learned in 45 years of studying intermittent exotropia, it's a topic that has been very, very interesting to me. It's really been a 45-year journey, and I think of it as a journey. I'm reminded of the words of Dante. He said in the Divine Comedy, "Therefore, for your sake, follow me, I will be your guide."
But
when I think about exotropia, I'm wondering if Karen Russell's words are a little more appropriate. No one can ever get to hell without assistance. Let's see if I can take you on a trip and avoid that. So the history of this journey, it started in 1970 when I was a first-year resident, and I learned Burian's classic classification of intermittent exotropia: divergence excess, basic, convergence insufficiency, pseudo-divergence excess. And according to Burian, the classification determined treatment. And subsequently, this was concretized. 70 years later, people are still citing this classification. But when I first heard of it as a first-year resident, I felt that there were internal incongruities and inconsistencies. I'm reminded of the fact that one of the fathers of psychoanalysis, Carl Jung, always said that your children live out your unfulfilled fantasies. And this is a picture of my daughter's first vehicle and the bumper sticker that she carried, so that she had on it. So either she got that from me or I got it from her. How did these ideas evolve? You know, in Greek mythology, it said that Athena sprung fully formed from Zeus's head. And this is a metaphor for a hypothesis that comes fully formed at conception. And my ideas of intermittent exotropia are not that. I think of it more like Sisyphus, building it brick by brick. Every step you go uphill, take 2 steps downhill. It was an ongoing evolution, but let's embark on the journey and see where it takes us. When intermittent exotropia, when a patient presents with intermittent exotropia, there are 2 important things you need to pay attention to. One is the control, and that tells you if you should treat the patient. And the other is the angle, and that tells you if you're going to treat it, how much you need to do. And I think it's very important that you develop a control score. Now, it doesn't matter in my mind what score you use, as long as you're consistent and it's internally consistent for you, in that when you look at a patient today and say the control's fair, you compare that to your notes from a month ago, does that categorization of fair mean the same thing? I personally prefer a 2-phase control score. Most of the published ones conflate how easily a patient breaks. They break after a prolonged cover, after a quick cover, spontaneously perhaps, and how quickly they recover. So they may say, well, good control is they only break with a prolonged cover, they recover very quickly. I find that control and recovery don't always go hand in hand. So I have one scale that I use to determine how easily a patient breaks fusion, and a second number that I put on it, or label I put on how quickly they recover. Now, if a patient presents with intermittent exotropia and they're very young, and I'll say approximately 3 years of age, there's a high incidence of postoperative monofixation syndrome if you do surgery in this early age period. It's not clear, is that due to the initial overcorrection in a very young child, if they're esotropic for even a matter of several weeks, they may lose bifoveal fusion? Or is there a pre-existing selection bias? Is it the patients that have a poor fusional mechanism that come in with poor control at a young age? This isn't really known. So I take the approach, I temporize if I can, and if I can avoid surgery at a very young age, I will. If I can't, if control is very poor and I have to intervene when a child's very young, I want to avoid a long-standing esotropia postoperatively. So although I still like an initial overcorrection, I won't let it sit there very long. I'll immediately intervene, perhaps after a week, with alternate patching, with prisms, possibly phospholine iodide. I don't want that young child staying esotropic for a prolonged period of time. Indications for intervention, most people go with something like atropia manifested 50% of the time or more. I'll also add to that worsening control according to your control score, or symptoms, diplopia and asthenopia being the 2 main ones that would be relevant in this situation. So my initial intervention with most children with intermittent exotropia is a non-surgical management protocol. And I'll begin with alternate occlusion, usually 3 or 4 hours a day. And I do this for anti-suppression. It's not amblyopia treatment. And the fixation pattern determines the the way I rotate the patching. If there's free alternation, which is actually quite uncommon in intermittent exotropia, I'll do alternate eyes, alternate days. If there's a fixation preference, depending how strong it is, I'll go 2 days over the dominant eye, 1 over the non-dominant eye, or 3 in 1, depending on how strong the fixation preference is. And I find that this almost invariably improves not only the control, but it also improves the angle. And then I gradually wean them off the patching over a period of a month or so. And sometimes this is curative long-term, but often the problem recurs. If it recurs, I'll intervene again with the same program. I'll patch them, but this time, before I taper it, I'll introduce minus lens treatment. I know there's a recent study that suggests that over minus contributes to progressive myopia. They and the original proponents of this, Archempolsky, recommended 3 diopters of over minus. I tend to use 2 diopters and incorporate 2 to 3 prism diopters based in over each lens, which is equivalent as far as the amount of control you get to another diopter of over minus. And my own experiences, and I have looked at this, this does not appear to increase myopic progression. I'll keep them in prism, wean them out by the end of teenage years always. And I find that this conservative management protocol, although often curative, usually bides time, and it will certainly give me several years of conservative management where I can let the child be bifoveal more often, improve their fusion. I can get better and reproducible measurements on them. Now, if surgery is indicated, all patients, regardless of their classification type, should have a 1-hour patch test to see if the distance angle improves with monocular occlusion. They also should have a measurement obtained looking at a far outdoor distant target. Different patients will increase the measurement with patching versus the outdoor measurement. All patients need both tests, and you should operate for the maximum angle obtained. A note about the outdoor measurement: if you live in Connecticut or Wisconsin and it's winter and you don't want to step outside, you can take the patient to a window. But as shown here, the distance of the patient from the window affects how much of their retina is subtended by the outdoor illumination. This eye is X distance from the window, and according to this hypothetical drawing, the window illuminates a 70-degree arc on the retina. If they're twice as far, it's only 30 degrees. So you want the patient to stand as close to the window as they can, still allowing you enough room to get in front of them to get measurements between them and the window. So this phenomenon where many patients increase their measurement when they look at a far outdoor target, I just refer to this as outdoor sensitivity. And I was interested in whether it's the increased light or the increased distance that is important. And it turns out, looking at this rigorously, it's actually both. Neither just increasing the distance or just increasing the illumination in a standard 6-meter lane is adequate. You need to invoke both the increased distance and light, and as I say, measuring them, looking at a target outdoors is the way to do that. Now, let's take a look at this hypothetical patient. There's a very common intermittent exotropic patient. Let's say they're 30 distance, ortho at near. And if we monocularly occlude that patient for an hour, many of these patients will increase their near measurement. In this hypothetical example, it equals the distance measurement. I referred to this phenomenon initially as a patient having tenacious proximal fusion. It was as though they had a strong fusional mechanism at near, which didn't let go with a simple cover test. I now, for complicated reasons, just refer to as the Scobie phenomenon, after Richard Scobie, who first observed this. And I would say to just think of it as the patient that has this has a better prognosis than the patient who doesn't. Now, where I differed from Burien with respect to his classification was mainly in this area. What he called a divergence excess patient who's greater at distance than near, I think probably doesn't have an excess of divergence. I think they're just an exotrope with an excess of some type of neuroconvergence. It may be accommodative, it may be fusional, it may be the Scobie phenomenon. The basic equal distance and near, I don't have an issue with that other than it's a strange term, nor convergence insufficiency. I'm going to talk about that in detail in a few slides. And then there's the pseudodivergence excess. That's the patient who has this Scobie phenomenon. If they are patched for an hour, their deviation at near increases. And I would point out that the use of +3 lenses and a patch test are not the same. They're not interchangeable. One relaxes accommodative convergence, the other relaxes fusional convergence, yet paradoxically, both may diagnose the same patient as having pseudodivergence excess. And I'm going to take a look at that and we'll see why, because it's not explicitly graspable. So an important point in understanding this is that ACA ratios in intermittent exotropia can be calculated in all the usual ways, provided that any near measurement that goes into the calculation is made after you've eliminated the effects of the Scobie phenomenon, tenacious proximal fusion, with a patch test. That phenomenon contaminates the near measurement if you haven't eliminated it. So let's look at an example. Here's a patient, 30 distance, ortho at near, haven't patched them, +3 lenses, their near deviation increases. Is this a high ACA ratio? Well, according to the calculation, ACA ratio should be 10. That's high. 3 diopters gave us 30 prism diopters of change. That's an ACA of 10. But in fact, it's probably not, because we didn't first eliminate the Scobie phenomenon, tenacious proximal fusion with a patch. So if we took the same patient as seen on your right, 30 distance ortho near, if we patched them, they'd be 30. Hypothetical patient, very common. Then if we introduce +3s, they'd maybe only increase another 10 prism diopters. It's an ACA ratio of 3.3. And that is, in fact, normal. So this is a pseudo high ACA ratio, which is what the majority of these patients have. Now, there is a very uncommon patient with intermittent exotropia that has a true high ACA ratio. And it's very, very important that you identify these patients preoperatively. So this is characterized by a patient where the distance is greater than the near deviation does not increase with a patch. It does increase with +3 lenses after a patch test. Now, if you test the ACA ratio with a gradient method, minus lenses in the distance, or here the +3 after a patch at near, it's a high ACA ratio. And another tip-off with these patients, if you measure them very near, like at maybe 3 inches, closer than we usually do, they show an esophoria, where your typical intermittent exotrope, you will be closer than the near point of convergence and they'll break and you'll see an exoshift. Now, why is it important to identify these? Well, in my experience, if these patients undergo surgery in the usual manner, 100% of them, in my experience, will have an esotropia at near if you surgically correct the distance. And I found that meeting these criteria that I gave has 100% sensitivity and 100% specificity for predicting a postoperative esotropia at near. How do I treat them? Well, because they have a high ACA ratio, minus lens goes a long way. A small amount of minus corrects a lot of deviation because the ACA is high. So I'll over minus them, whatever amounts needed. They do need a bifocal at near because they have a high ACA, which in my experience always normalizes by the end of their teenage years, at which point they can successfully undergo surgery in the usual manner with the usual formula. What's the role of prism adaptation in these patients for diagnosing the pseudodivergence excess? Well, classic prism adaptation, Fresnel prisms, wear them for a week or two, has not rigorously been studied. I have done in these patients a form of very rapid prism adaptation. I'll put base in prism equal to their distance deviation, have them sit there for just a minute or two, cover test them, and the near deviation builds. It's qualitatively, but not quantitatively the same. So this is something that I think is worthy of a prospective study, which actually I understand is currently being done on a collaborative basis. Now, with respect to surgical recommendations, Burian's recommendations were based on several false assumptions. He assumed that lateral recessions affect the distance greater than the near, and a recess-resect affects the distance and near equally. And I think that this has really been well disproven by Steve Archer and others, and my own work confirms this. So my thoughts are that most divergence excess patients, so-called, are really masking a larger near deviation that just hasn't been brought out. And you could do lateral recessions or recess-resect, your preference. The basic patient, the patient that does not have the SCOBY phenomenon, they have a poor prognosis and you need to do more. An R&R can be successful, but I also find that lateral rectus recessions, this was from a study done in Korea, can be equally effective as an R&R if you use an enhanced formula, add a millimeter or two to your recession of each muscle. And the pseudodivergence excess, SCOBY phenomenon is present, take your pick. Lateral recessions, recess-resect, whatever you like. Now, a word about convergence insufficiency. And what's not widely recognized is we use this term to describe two different types of patients. On your left is the fusional convergence insufficiency. This is a patient with a trivial phoria at distance, not a tropia, a bigger near phoria, and they have low fusional convergence amplitudes. These are patients that do well with convergence exercises. Contrast that with what actually turns out to be an accommodative convergence insufficiency. These are the patients with a small distance tropia, intermittent exotropia, a larger one at near. They may have normal accommodative amplitudes, but if you test them rigorously, you will find that they have a very low or possibly absent ACA ratio. And that's why there's probably no surgical procedure that'll really equalize their distance near difference. You can do medial resections for the distance. You can do an R&R for the distance, and then treat the near deviation optically with prisms or separate reading glasses and so on. I personally have added something that I call the Buckley procedure to my treatment of these patients. Ed Buckley described this, and that is to create a V pattern when one isn't there by whatever surgery you do, either moving the medials up or the laterals down, about 3/4 of a tendon width for each, and that will induce a V pattern of about 7 or 8 prism diopters. So you operate for the distance deviation, create a V, which will help for the near down gaze reading position. And I think that's the most effective procedure that I've come across. So just a word now about lateral incompetence. You know, this was described many years ago by Phil Knapp and Sally Moore, that some patients with intermittent exotropia if their deviation decreases in both right and left gaze, here it's 30 primary and 15 in right and left gaze, there's a very high incidence of overcorrection in primary if you operate in the standard manner. Now, if you look at that, conceptualize what could cause an exo to decrease in both right and left gaze. And I can only think of two things. If the laterals are weak, it would happen, but it's hard to fathom weak laterals in a patient with exotropia. Or the medials are overacting. And to me, that must be what explains it. And that explains why they're prone to overcorrecting. If you have overly strong medials, you weaken the antagonist lateral rectus muscles, the medials take over, and you end up with a postoperative esotropia. Now, some people have felt that this entity doesn't exist. Moore and Knapp felt it was very common. There was a big study from Wilmer suggesting it's an artifact of measuring. My own experience is it occurs, it's real, it's not all that common. But you should be aware of it and be cautious of it. But I want to contrast this with the patient that has this iatrogenically after prior lateral rectus recessions. So here's the same measurements, 30 primary, 15 right and left. And here's a patient that's had lateral rectus recessions. This is a different situation. Now the laterals we know are iatrogenically weakened. So in this case, they would not be prone to an overcorrection in the primary position. And you don't have to worry about that. They may be overcorrected in side gaze because the deviations are smaller, and you have to take that into account, but you don't have to worry about the primary position overcorrection. Finally, I want to just talk about surgical goal. I like my intermittent exotropes to be immediately overcorrected. I personally like 5 to 15 prism diopters. More than that, I wind up usually having to intervene again. But, and I expect a lightning bolt to hit me when I say this, I do not overcorrect adults. I find that adults don't straighten the way children do. I usually use adjustable sutures on adults, and I like to adjust them so that they're just ortho and primary, bordering on diplopia a little bit to the right and left if I've done lateral recessions. And that gives me my best outcome. So in summary, we've talked about when to operate, not to operate terribly young, protocol for conservative management, surgical measurements. All patients need a patch test for distance, a far outdoor distant target measurement. We talked about distance near differences, the importance of the Scoville phenomenon and its effect on surgical planning. A little bit about convergence and sufficiency, the two types, the true high ACA ratio, intermittent exotrope. Beware of them because they'll go ESO at near if you don't identify them and operate. And I overcorrect about 5 to 15 in children, not in adults. And I want to thank you